the treatment of attention deficit hyperactive disorder. As an introduction, this paper, I wrote a paper on treatment or the challenges in treatment of attention deficit hyperactive disorder, which is known as ADHD, because the treatment is challenging, and we will show now in this presentation why it is challenging and what is the solution for that. To your knowledge, mental disorders.
Hello, Dr. Mustafa. Sorry for the interruption.
Yes.
Could you please put your screen in full slideshow mode?
I put it what?
Slideshow mode.
Reachable how? I mean, I share the screen. What should I do? Can I send it to you? Can I send it to you?
No, we do have your presentation. Can we share it from our side?
No, I share. It's shared in front of me here. I don't know what should I do. It's shared. Okay, I'll stop sharing. I'll stop sharing and I will share it again.
Sir, you can do slideshow. Slideshow. You go for slideshow and from you can click for correct.
It is there in. Where is the slideshow?
It is in home page, no, sir. Just seeing it here, I will tell you from design and slideshow. From animations side, it is on the animation. First one is the transitions and then animation and slideshow. You go for slideshow.
Make it big.
Yes.
Okay.
Yes, now it is done.
Yes,
it is good, sir.
Thank you.
Okay, thank you very much. The introduction, like I told you, the treatment of mental disorders is very challenging. Why? Because mental disorders in general are went either unrecognized or untreated. There are a lot of challenges in front of healthcare providers, like stigma against mental health, the scarcity of mental health service, the awareness of the population, the limited action. Sometimes in some countries, the cost of treatment is very high. And we will focus today about the atypical presentation of these mental disorders, namely ADHD, and its comorbidity with mental and the physical disorders and the cultural shaping of this presentation, because ADHD presentation is different in different cultures and in different nations. The culture shaping of some mental disorders and atypical presentations, I'll give some examples about it. For example, the atypical depression. Atypical depression usually goes either in teenage or among elderly. In teenage, if he has a depression or she has a depression, she will not complain of sadness and bad mood, but she will complain of weight gain or for rejection sensitivity or for excessive sleep, hypersomnia. And if among elderly, they will complain of somatic manifestation, they will complain frequently, for example, from rheumatic pain, headache, migraine. This is the elderly presentation. Among elderly and among teen, the depression presentation is called atypical depression or atypical presentation. There is also atypical somatization. Atypical somatization, it means somatization, we know that the patient himself will not be aware that his problem is purely mental disorders, and he will have frequent somatic pain irrelevant to each other. Atypical suicidal ideation. The terrorists, for example, or the people who are work as human bombs. This is called atypical suicidal ideation. They resulted to other religious disorders. So atypical presentation and culture shaping is very common in mental disorders. What is the methods of this paper or this study? It's narrative review paper. It's not a systematic review paper. In PubMed, I put some keywords and I use the word treatment, management, and therapy using the Boolean or and attention deficit hyperactive disorder or ADHD. Then I combine them together, and 282 papers came to me. Out of them, 74 articles or papers, which is constituting my research paper, come, and I summarize these 74 articles in this presentation. Now, why doesn't come? The results. ADHD is most famous and common neurodevelopmental disorder. Neurodevelopmental disorders, it means it happens to children in the first 3 years, and its manifestation starts to appear in the 3rd year. Neurodevelopmental disorder. The most common neurodevelopmental disorder is ADHD. Comes after it the autism and the autistic spectrum disorder. And there are a comorbidity between the both, as we will see in the next slide. Its treatment is challenging because the disease comorbidity. We will see around more than 12 somatic or mental comorbidity with ADHD, which may mask its presentation, which they may disturb and confuse the healthcare provider or the psychiatrist or the GP from proper diagnosis and treatment. And I had a book on the ADHD and metabolic syndrome, which is recently published as an example of the somatic comorbidity with ADHD. Discussion. First of all, we will list here the comorbidity of mental disorders with of ADHD with mental disorders. With ASD, which is autistic spectrum disorder, 95% up to 95%, both disorders are comorbid. The second one is substance abuse. ADHD can be found among adult substance abuses up to 60%. If you try to screen the substance abusers, research found that up to 60% of them are ADHD. Number 3, emotional dysregulation. We know that emotional regulation is one of the most important cornerstones of executive function. Emotional control and emotional regulation. 54 of the ADHD patients, either children or adults, have emotional dysregulation or emotional deregulation, and that's why they are victims of depression, because emotional regulation and the prevention of depression is very important. Emotional dysregulation and depression are associated with each other. That's why 1/3 of the patients with ADHD have depression. And this depression, 1/3 of it is called treatment-resistant depression, which is not responding to one drug or even two drugs and the depressants. It's called treatment-resistant depression, like hypertension, treatment-resistant hypertension. This is treatment-resistant depression. And the percentage is high among ADHD. Number 3, epilepsy. Epilepsy, the next number, I mean epilepsy. Epilepsy are more common, 3.4 more likely among ADHD than normal population. If you compare ADHD and normal population, you will find epilepsy among ADHD are 3.5 more likely than normal population. Executive function, EF, it means executive function. Impairment denotes the severity of the symptoms. And executive function have main 3 components. Number 1, the emotional regulation. Number 2, the working memory. Number 3, the flexibility. These 3 components are impaired among ADHD. Then we will shift to the comorbidities of the physical disorders. ADHD is common among atopy. 20% of the ADHD are atopic. ADHD is 2 times more likely to develop testicular dysfunction. I have my friend who is an adult ADHD. He is sterile because he developed testicular dysfunction. ADHD, 90% of them are amblyopic, having lazy eye, and where the community is full of ADHD patients, even subclinical symptoms, you will find all of them wearing specs even in young age. 80% of the ADHD having astigmatism, and they are twice likely to develop heteropia. Continuing the physical comorbidity with ADHD, they had gluten sensitivity, celiac disorders, irritable bowel disorder. This is very important because a patient can come to the nurse or to the doctor or to any healthcare provider complaining of these things, but the healthcare provider didn't put in his mind to screen for ADHD. ADHD is related to something called gut microbial composition and zonulin. What happened? Then the gastric permeability due to absence of some microbes is leaking, and this leakage is associated with autoimmunity, and it could be the cause of ADHD, and it could also be the cause of metabolic syndrome. That's why the gut microbial composition and zonulin. Zonulin is a chemical or hormone of protein, which you will find it high in blood in case of this dysbiosis or increase gastric permeability. And also it's related to obesity, dyszonulin, metabolic syndrome, and diabetes. So to summarize this point, because this is very important, there is something called dysbiosis. It means some beneficial microbes are not there, and there is increase in the gastric permeability of the stomach, and that can lead to autoimmunity, obesity, metabolic syndrome, diabetes, and ADHD. That's why they are comorbid together. Also, research prove that adult ADHD, when they are getting age, they are more likely to develop cardiovascular morbidity and mortality than others. After I show now the association of ADHD with comorbidity, either mental or physical, I will talk about the treatment. If we talk about the treatment, we have always to keep in our head the association of or the comorbidity of ADHD with other things. We cannot only treat ADHD. And in the next slides, I will show you how. There is a neural correlates or neurobiological link between ADHD, ASD, and dyslexia. So if you treat ADHD without screening of ASD and dyslexia, you are neglecting a very important comorbidity, and you are neglecting a very important part of treatment. Living in green areas. This is another way of treating ADHD, because they noticed that people who are living in very vast areas, green areas with environmental cleanliness, there is no environmental pollution, ADHD prevalence is inversely associated or correlated with these green residents. Micronutrients. I just talked to you about the dysbiosis, and this dysbiosis, the only is probiotics and prebiotics as treatment of it. Added to probiotics and the prebiotics is the micronutrients. It's a vitamin and mineral treatment, because it improves, number one, attention. It proves attention among the ADHD patients, and it improves the emotional regulation. But they show that it doesn't improve the hyperactivity, only the attention and the emotional regulation. ADHD and sleep. ADHD is usually comorbid with bad sleep efficiency and shorter duration of sleep because of the disease itself and because of the stimulants that the patients are taking for treating their ADHD. I mean, sleep disorders is linked because of two things, the disease itself and because of the medication. And sometimes, because sleep disorders is the most common disorder we encounter in psychiatric clinic or even in general practitioner clinic. I don't sleep well, doctor, or I don't sleep well, nurse, or my pain is becoming better, but still I don't sleep well. So sleep disorder is very common nowadays. Don't forget to screen for ADHD among people who are complaining of sleep disorder. Another factor that can link ADHD with sleep disorder is the addiction to the smartphone. The ADHD people are impulsive and they are more likely to be addictive to smartphone. I have adults with ADHD, they cannot leave their smartphone from their hands. All the day, the smartphone is ringing. So addiction of smartphone, especially by night, one of the causes of their sleep problems. Another factor is the association of ADHD with depression, and we all know that depression can play a role, or the association of ADHD with bipolar disorder, which cause insomnia. That's why we have to think comprehensively. If anyone come to you with sleep disorder, think of ADHD, think of depression, think of bipolar, think of smartphone addiction, think of treatment of the ADHD. Another way of treatment, it's called exergaming. This exergaming, we all see it in malls, in big malls here in Malaysia or in Dubai or in any Arab world. I have no idea about India, but these exergames where the artificial intelligence make you doing exercise, you can play tennis, you can box virtually, so many things. These exergames help to make you lose weight, help you in obesity, help you in diabetes, help to improve your executive function, help to control your metabolic syndrome. It's like cycling. Sometimes you are riding a virtual bicycle or doing boxing, for example, so it's called exergames. Here I want to tell you about the association of ADHD with emotional dysregulation and impulsiveness. These two things can bring the ADHD patient, especially if he is an adult, to criminal conviction, can cause a lot of cases of domestic violence, like intimate partner abuse, for example. And you cannot treat ADHD without taking these social trajectories or social drawbacks in your mind. There are many ways to treat ADHD and its comorbidity. The most famous are the stimulant drugs, because actually ADHD is like the brain is sleeping. The brain is not active enough. So the man or the woman or the child, whatever his gender, he is trying to move a lot to make his cognitive function alert. This is the idea of linking the poor attention with hyperactivity. We are giving stimulants to him or to her to stimulate the brain and make his movement much less. Make his movement much less. We can do cognitive therapy, which is called metacognitive therapy, or mindfulness-based cognitive therapy. And this is a new type of cognitive therapy depending on the mindfulness. What is the mindfulness? Is the complete awakefulness of the brain. Complete awakefulness of the brain. Sometimes you are getting up in the middle of the night, for example, and going to the fridge and drink and get back to your bed and sleep while you are semi-awake. You don't know exactly at what time, you don't know exactly you drank a lot of water or little water, you are semi-awake. And like awake, semi-awake, and the full awakefulness, there is mindfulness. Your mind is very awake, so no need for you to be talkative, no need for you to be impulsive, no need for you to move more than your colleague. And this mindfulness comprised of three things: intention, attention, and attitude. Intention, to improve yourself. Attention, having full attention to your motives. And good attitude, not impulsive attitude or aggressive attitude, as a lot of ADHD students, not students, patients are there. And research compared between the mindfulness-based cognitive therapy and the treatment as usual, TAU, with stimulants. And they found that the executive function is much better if we combine both. Non-invasive brain stimulation. We know also that recently, in the last 10 years, there is something called brain stimulation. There is non-invasive from outside and the invasive or transcranial direct brain stimulation. They are treating ADHD. They started with depression first, then they are going now to the ADHD. Again, because of its importance, dysbiosis, gut-brain axis treatment, and gut-brain microbial gut axis treatment, and the role of probiotics, the prebiotics, and vitamins and nutrients. Don't forget that. Some of the ADHD patients, even while they are young, they are having excess caffeine intake. And caffeine is not solely by coffee or tea, even by Coca-Cola. So you will find that children are 2.5 times more likely to consume coffee than caffeine intake or coffee or Coca-Cola than others. There is a gender difference. It means difference between male and female in ADHD, either in its symptoms, utilization of health services, treatment. All of these things are less among females. And females also are more likely to have missed the diagnosis of ADHD. Exercise and ADHD. As exercise help treating depression, help treating ASD, it also help treating ADHD. And we had a PhD student here, exercise and ASD, autistic spectrum disorder. So exercise treat ADHD, ASD, and depression. One of the social problems is road traffic accidents. Wherever you find road traffic accidents is high, suspect ADHD, like in Gulf. In Gulf, RTAs are very high due to high percentage of ADHD. The last slide, we want to focus on two things. Number one, the comorbidity of ADHD with mental and physical disorders. Number two, we recommend to conduct more clinical studies, especially longitudinal study, because the presentation of ADHD change over time. Its presentation among children different than among adolescents, different among adults and different among the elderly. Not only the presentation, its types of comorbidity are also different. Thank you very much.
Hello, everyone. I am myself Dr. Pratibha Desai, the Associate Professor, Department of Sociology and Shivaji University. Before starting my presentation, I just want to share with you that this paper is based on the community health workers. That especially we called them in India the accredited social health activist and ASHAs. That is the ASHA. The short form of this community health work are the ASHAs, and that means in India, the NRHM scheme was implemented, National Rural Health Mission, and that was one of the milestone to improve the maternity and child health, particularly in the context of the rural people in India. In accordance with the utilizations of primary healthcare center, the people are not well aware about these the utilizations of primary healthcare center, which is to be the free of cost. But how can to increase the utilizations of this health? So the government of India has implemented this scheme to build up the relations between the community and as well as the health worker. So these are the community health workers. Those are very important and bridge between the people and the government or the primary health center. Just I will start with my presentation. You know all about what is the health. Health is the prerequisite and the requisite component of well-being and development of any individual or society. It is the multifunctional concept which is not only meant for the medical care, but also relating the socio-cultural, educational, economic, and political development of the society. We just, in case the earlier, there was the presentations of the mental health, but health has been that means very different aspects. That is socio-cultural aspect, as well as the mental aspects, as well as the physical aspects. And whenever we address the health, we have to take all the factors or all the factors in concern with the health. So we all are aware about the World Health Organizations defines the health as a state of complete physical, mental, and social well-being, and not merely the absence of disease and the infirmity. That means health is only not the physical, but it has also a person who is to be called, he is to be physically well, mentally well, as well as socially well-being, not merely the absence of the disease and the infirmity. So we are aware about that. The 2-3 that means the 2 years back, the same time we are facing the COVID-19, which is not the epidemic, but it is the pandemic, where overall the world are suffering from that. And to control the COVID, many people are working for day and night. For example, doctors, nurses, and we all people are sitting the day night, and they are suffering from many. They are taking the personal risks, lost their lives, their family members, and they are not paid full or regularly. That means the community, particularly the community health workers, they are working on honorarium base. So these people are going for the field work in the COVID period, but they are not paid regularly. They are giving the honorarium for the incentive based honorarium. And these community health workers, particularly ASHAs, played an important role to control the COVID-19 in the rural area. So hence my paper focuses on the problems or what the ASHA workers and how their life was in the COVID-19 period. What exactly their personal life they are facing, family life they are facing, and what problems they are facing, I have taken in my study. And this one is the introduction. Just a second slide. Hello.
Yes, correct.
Second slide.
Yes.
See that particularly the government of India has implemented these schemes for the ASHA. Particularly, Union Cabinet Minister increased the amount of and routine and recurring incentives for these ASHA workers for particularly the COVID period at the 2,000 per month. against earlier allocated the fixed amount 1,000 rupees, and the incentives are given on the performance basis. But due to the contributions in the COVID period, 2,000 per month was to be given for ASHA workers. And next, the ASHA workers are also given the life insurance, accidents insurance, pensions. For example, Jeevan Jyoti Bima Yojana, Pradhan Mantri Suraksha Bima Yojana, Pradhan Mantri Shrama Yogi Yojana, and ASHAs are given the Pradhan Mantri Garib Kalyan Yojana package, which is to be particularly for the ASHA workers, where it covers the insurance for 50 lakh rupee in case of the life due to COVID-19 and accidental death amount due to the that means anything. For example, they are working in the field, they are going one village to the one village, home to home, and house to house, so that some accidental cases will be happen. For example, snake bite. For example, sometimes in the COVID period they were beaten also, and sometimes their that means household utensils were also destroyed by the villagers. At that time, this accidental death for working at like loss of life due to the COVID, or for example accidents, because in the transport facilities that are not to be provided for them, but sometimes they are affording any other, for example trucks or something else, and accidental death also given to for them. And next slide please. Next slide please. Excuse me, next slide please. Hello. Hello. Hello.
Hello.
And next slide.
I think the people managing the slideshow at the other end will have to help you.
They are not there. 1 minute. Hello.
Yes, I think it's moved now.
Yes, ma'am. And this one is, I have taken study in the Kolhapur district. I am living in the Kolhapur district, which is one of the district in the Maharashtra state from the India. And Kolhapur is the semi-urban area. It is the B-grade city, where in the first COVID phase, there was no much problem. But at the second period, it was to be the much problem. Second wave of the pandemic, much it was affected the Kolhapur district, and Kolhapur administrations, district administrations has done commendable job for by controlling the infections, and role of these community health workers are to be the very important. And this district also played very important role in the vaccinations throughout the Maharashtra state, leading one of the important districts due to these community health workers. Next. Hello, next slide. Hello. 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 Hello.
Yes, we can see your next slide, the review of literature.
Yes, ma'am. This one is the review of literature. And I think that I will go through all point to point, or I have time of 20 minutes, no?
Yes, please go ahead.
So just for this study, because this my study, that means my paper is one of the that means we are one of the part of my major project, the community health workers contributions in the pandemic period, which was sponsored by Indian ICSSR, Indian Council of the Social Research and Social Science Research, and this project was to be funded by them, and I acknowledge much very them. And I have taken the many much reviews, and that are from Brazil, Africa, India, United States, Syria, where this type of parallel to community health workers, that means they are same to the ASHA workers, and they are to be also playing important role. What happens about these that community health workers at the world level, when we know that many of the South Asian countries, either Asian countries, have the shortage of the human resources, particularly in the health sector, and that these are the paraprofessionals people, and these are the community health workers, and this type of the community health worker scheme is also in many Africa also, Brazil also, China also, and they can bridge the gap between these human resources, because this shortage was to be filled by particularly in India by the ASHA workers. So many studies, there were much not at a research level was not to be done. Only earlier COVID period, many community health worker studies were taken in the context of the maternal health, health and child health, other the health status of the rural people. But after pandemic, in the period of the pandemic, the ASHA workers' role was very important, and that were not conducted at micro level studies or big studies, big research oriented studies, but many newspapers are that World Health Organizations, very local level, and some small studies were also focused their important roles in the controlling or contributions of the ASHA workers. Next. Hello. And this objective of my study, actually for this paper, I have taken one objective only, to understand the life of the ASHAs at the time of COVID and the problems they faced in the periods. And I have taken the contributions also, their personal informations, many more things, case studies in my project. For this paper, I have focused only to the life of the ASHA at the COVID pandemic. Next. And methodology. For this particular paper, I have selected the Kolhapur district, and the Kolhapur district has it was to be the geographically it was to be the one of the important region which comes under Western Maharashtra, and overall the Maharashtra district was to be the divided geographically, historically, political science, politically. It was to be 5 main regions: Vidarbha, Marathwada, Khandesh, Konkan, Paschim Maharashtra, and Western, that is to be called as a Western Maharashtra. And Kolhapur district is located in the Western Maharashtra, and Western Maharashtra consists of 5 districts, which is to be called Sangli, Solapur, Satara, and Pune. You know, I think that Pune and Mumbai are to be world level popular. They are to be the metropolitan cities as well as the districts. And Kolhapur is to be the big red city, where in this district there are the 10 talukas. And for that 10 talukas, the ASHA scheme for the particularly Kolhapur districts was implemented in the 2008, and total in ASHA in these districts, total 2,773 ASHAs are to be the working. And total in 10 talukas, the Kolhapur districts has the 70 PSC, primary health centers, and 1 PSC covers 30,000 populations. And in this district, 2,073 ASHAs are working. That means 1 ASHA covers the 1,000 populations. The ASHA is to be the selected for the, or she is given the work up to work in her area allocated is to be the 10,000 populations. And 1 PSC has nearly, that means 3,000 population. It has to be nearly 30 to 50 ASHA workers. That means population is to be the more, and less number of the ASHAs are to be the working. And the ASHAs presently working in the pandemic and linked with prospective PSC, it is also taken that I have taken 16 PSC. That means 50% of the PSC, and out of 50% of the PSC, I have taken 40% of the ASHAs. That means 1,219 ASHAs are there. I have taken 493. My sample is to be 493 were selected for the present studies by using the random ASHA random sampling ASHAs. And while taking the samples of the ASHAs, the care was taken that whether the ASHAs are actually working, they are giving the contributions to the pandemic control, or whether are they are to be currently worker, because some ASHAs are joined and they left because of many reasons. So working ASHAs are taken to for the personal interviews, and I have gone for their houses, I have gone for some PSCs, and I have attended their meetings. Sometimes due to acute, many times it is not possible to go for ground field work because people are not allowing us, because it was to be the pandemic. Although I have conducted many online meetings also of the ASHAs to get the inside of their work. Next, ma'am. Hello. This one is the one I have taken and I have analyzed my data, processed my data and analyzed, and I have presented. I have taken the personal, that age, religion, and marital status by the respondent. That means ASHAs. Out of them, many ASHAs are 36 and 45. This ASHA scheme is particularly for women from the villages, married women, and sometimes if married women are not available, unmarried also given to the chance to work. And many of the married women, out of them, some are the widows and some are the separated, divorced, and they are given to the work. And these ASHAs are only 7th pass, they have passed the 7th class primary, or some of them are passed the second. The criteria for selection is the 7th standard. So many of the ASHAs are those who are left their schooling, and some of them are not getting the that means not chance to get the higher educations, and somehow that means sense of the social work, and many of them are from the 30 to 45 years after the family household works are to be, that means after the married and having the children, and this one is the proper age to join them, 36 to 45. And religion, this one is the religion composition of the ASHAs. Many more of the ASHAs are from Hindu, some are the Muslim, some of the Buddha, and others mean here Jain, Lingayat. These are also the religions, because India has the very diverse diversity, and it has also religious diversity, language diversity. So that's why different religions are to be found in the Indian context. This was the marital status, where majority of the married, and some are where there is not available, because the selection of the ASHA criteria is one that they should have the residents from same villages. So if married woman is not available, they have given preference to the unmarried also. And some are the divorcee, widow, and separated from the husbands, because this area that many ASHAs are having the single householder, and they are only earner of their families, and this one is the source for their livelihood also, and it is good for the health of the rural people, improvement of the health status of the rural people. Next one. Hello, next ma'am. And this one is the educational higher secondary education. Even though their criteria of selection is to be the desirable is to be the no more, but compulsory they have to pass the 7th standard. But here educational status shows that majority of the ASHAs are getting the higher education up to the that means higher, that means 10th or 12th standard, and number of year experience, because here ASHA is to be implemented in Kolhapur district 2008. So they have more experience, more than 8-year experience of the working as a ASHA workers. Next. This one is the honorarium, the monthly honorarium. See that 5 to 2015, 25 to 500, and majority of the ASHAs are getting the 2,000 to 5,000 rupees. Because actually the guidelines of ASHA told that they should work for 1,000 population for 2 to 4 hours, at least 4 hours or 2 hours by their only 1,000 populations, and they have the incentive. For example, accompanying with the delivery persons, they have incentives of 250,000 for immunization, 100 rupees for giving the awareness about the COVID or vaccine, something that they are all the incentives. So their monthly honorarium, as per the incentives, they can get maximum 2,000 rupees to 500 rupees. And in COVID pandemic, it is pending from central governments also, and it is pending from Gram Panchayat also, and it is pending from state government also, because actually they are getting the honorarium incentives, but they are getting their contributions, but their honorarium is not giving regularly. It was to be the pending. Next, ma'am. Next, ma'am. Hello. This is the at the COVID period, the many ASHAs told me that they have taken the loan. If we all people know that we will take the loan for purpose of the education, any other things. But in pandemic period, we seen that ASHAs are taken the loan for fulfillment of their daily needs, because many ASHAs are only the source of earners in their families. So pandemic period, they are getting that because pandemic period, in that pandemic, they are getting the fixed honorarium 2,000 rupees for the COVID work. But for non-COVID work is to be the left behind. For example, immunization, that is that means maternal health care or any others for survey. These are all left behind because COVID has overtaken all these diseases. And so that's why, because of non-COVID work, they are not getting their incentives, enough incentives to survive. So that's, they have taken the loan for their fulfillment of their daily needs. And some told me that for children's education, and some told me that for hospital treatment also, because these are the community health worker. There are the para-professionals, but they are not taking their, that means they are not having the free treatment, because at the COVID pandemic, the primary health servant government is playing very important not. But in serious cases, the more expenditure is there, so it is not affordable them for the sometimes and for the any other diseases also. Next PPT, ma'am. And this one is the distribution of whether I have taken the COVID, whether what are their positive, if they are positive, COVID positive or post-COVID health problems. They say that many of them have not the COVID positive because they have taken the care, and many of them have the after post-COVID, they have faced the health problems, and these health problems are like that. Next, ma'am. Hello. This one is to be the family. I have taken their family life first. The type of the family, many of the ASHAs are having joint also and nuclear families. And the rooms I have taken because while they are after the duty, they are entering into the there, they need to be the separate rooms because it is the contagious disease, and in the society, neighborhood, they are to be not taken into the neighborhood because it is the contagious. And the people, even the children of the ASHA workers are not to be allowed to go for the neighbor's room because all them saying are that ASHA are the major carrier of the COVID-19 at the school levels. I share one of the example. One of the ASHAs told me that when she went one household and she asked the water to drink, that women, she has taken to the knockdown, whether those who are coming from the cities, and she has to be tracing the COVID positive patients, and she has to be given the taking the details. And she went one of the one of the house and one of the bungalows where she went there, and she taken has the information. She asked that women, please, I'm thirsty and please give me the water. That woman said, you are the no, you go and you are the carrier of the COVID-19. I will not give you the water. And the ASHA went without taking the water. After when ASHA went, where ASHA was the sat, and she spilled the water and they spread the water on that places because she thinks that woman thinks that ASHA is the major carrier of the ASHA. So that's why rooms are also important for the house. In house, the rooms are in home. The rooms are very important because if rooms are the more rooms are there, then they can have to be the quarantine and at least they can separate it, and COVID will not be spread to their family members. The type of the house, many of the ASHAs having that means mud type house. Many of them ASHAs are not having the RCC type house. They are to the middle type of the houses. Next one. This one is the earner. When I said that who are the earner of their families, majority of the ASHAs are the earners, themselves earners are the families, and next to their husbands, and some of the ASHAs are the above 45 years, their children are also, and some are the parents are also, and their monthly income, it shows their monthly income, and monthly income is to be the about 3,000 and 4,000, 5,000, 6,000. Next, ma'am. And this is to be the when they are working for the COVID work, those who until unless the support of the that means family members, they are not possible to get the work in the COVID-19 period. But they are very lucky that they can get the support from their family, and they have also the isolated in the families. At the isolations, when they are isolated in the families, their household work was to be done by their childrens, even though their husbands also. And opinion about atmospheres, whenever I asked about the how the atmosphere at the COVID-19 period, it was to be the very, that means sometime it was to be stress and tensions in within the families, because they are thinking that if she is working in the, because work is to be the important for their livelihood, if work is to be the left, they can't do anything. So but in working in the COVID period, visiting to the ground level field works, then it will be bring the COVID positive to the their family members also. So there was the stress and tensions in the family, and many of the husbands of the that means some of the husbands of the ASHA workers lost their work also. It was to be the common for COVID pandemic. Many people lost their jobs. And next one. Hello, next PPT, ma'am. And this was to be the societal life of the ASHA workers, how the society treats them. And when I asked that how the society, you know, that society thinks them that they are the carrier of the COVID-19. So they never get the support from their, that means neighbors. They were treated isolated. Their children were treated isolated. Their family were workers isolated. But it is not only important, but in the community, they were harassed. They were troubled, and they were to be the, sometimes they were also beaten by, because in the vaccinations also they play very important role. While providing the vaccinations, that slot was to be the given to them. And some of people are thinking that we are not getting the vaccine due to the ASHA workers. So many of the gundas or many of the politicians, many of the, that means many of the peoples are so harassed these ASHA workers, because, and they were to be burdened with, because in village level, Gram Panchayati plays important role to control the COVID-19, and the Gram Panchayati, primary health centers and local people, they have to be worked together to control the COVID-19. But they have all left, because this is the intensive incentive based work, and they told that it is your work, you go for the field. And whenever they go for the field and the people thinks they are the carrier, or they are on sometimes on vaccine, giving the vaccinations, the caste based issues are also created, because she is from upper caste, so she allowed the vaccination from these people also. So they can much harassed by the ASHA workers from the at the community level. Next. And some were also taken also, that means they were also taken the support also. Next. Hello, ma'am. Next one. Hello. And this was, I have already told that 1,000 population was to be, as per guideline, 1,000 populations was to be the given, but more than 3,000 population was to be the covered by ASHA at the pandemic level. So it shows their overburden. They were to be the overburden of the work at the COVID pandemic. Next. Next. Hello. Next. And the key findings, already we have, majority of the respondents were at the age group of 36-45 years. Majority of the belongs Hindu religion. Majority of respondent of the married, and income dropped due to the COVID-19 pandemic. On an average, 12 months honorarium is pending. It shows ASHA workers were not paying regularly. They are borrowing the loan from hospital treatment. This is because being the health workers, they are not getting any free medical treatment. ASHAs are facing the problems such as body aching, weight loss, weakness, breathing problems, BP, and diabetes. After these are the post-COVID problems to be, that means faced by the ASHA workers. Majority of ASHA workers that they have 2 rooms, but on an average, ASHA worker had the 2-3 rooms in their houses for the isolation. Majority of ASHA have only ASHA work as a source of the earning. And researcher found that 2.2 ASHA's family members died because of COVID-19. And these members are the husband, mothers, and in-laws and fathers. Basically, while working through COVID period, ASHAs had faced many difficulties. Next. Next PPT, ma'am. Hello, next slide. And that contributions of ASHA is to be the very important, and they are to be the working for 1,000 populations, and that they had reported that they had work checking for the COVID-19 symptoms among villagers and putting seal on the hands. And they are also reported that they had done the work of preparing list of all ages for the vaccination and registration of the vaccination. Next, ma'am. Next, ma'am. Hello. And the problems, this is very important. At the COVID pandemic, their contribution is to be the that means unavoidable, and it is very important. Due to that, they are worked as a paraprofessionals. They filled the gap between the human resource in the health sector, and they are the honorarium based paid workers, and they are not the employees, and they are not covered under any, that means any major reimbursement, medical reimbursement or any payment. But they are facing n number of the problems. Their contributions is to be the not much to be that means is to be taken, and they are facing the irregular payments, meager income, health problems, physical as well as mental problems, drop in income, long hours of the work, because they covered actually 1,000 population is there, but they covered 3,000 population. And at the COVID period, when tracing for the COVID patient, they have to go, when a person came from in the night, they have to go and trace there, and they have to list for the house to house. So they actually their as per guideline, there are the 4 hours work. At maternal and child health care or health status of 1,000 population, they work for 4 to 5 hours. But COVID has increased their work hours long to about more than 9 hours. And overburden, lack of safety gears, for example, hand gloves, and for example, many other safety gloves are not to be given of them. Non-cooperation from village and Gram Panchayat adversely affect family and children online educations, because they are working. These are the people not much more than to be the income level, and they share one Android mobile within the home only. And one Android mobile they are working on, it was because it is COVID pandemic. They have to enter the data into the software. So they use the Android mobile, and parallel the online education of the children also going. Because of one handset of the Android handset, their children suffers from the online education. And lack of facilities in working place. There is no facilities of drinking water facilities, refreshment, toilet, and transport facilities. You know that I have seen that, and I have working from these people from 2016. They are walking 8 to 6 kilometers by walking only, because in interior villages there is no public transportations. And in COVID pandemic, it was to be the lockdown, so it is to be the worst condition in concern with the transport facilities. And additional work, non-cooperation for permanent staff, for example, nurse, doctors. And next, these are the major problems faced by the ASHA workers. Next slide. Hello, ma'am. Next slide. The conclusion of my paper is ASHAs are particularly known for maternal health care in rural India, but now they had become the front warriors in the fight of COVID-19. And with taking the risks, they are working for day and nights, but still they are giving the meager payment and non-cooperation with the community. They are also one of the important vulnerable human resource in the work health force. We should know that they are the paraprofessional and filling the gap of shortage of the health force. So it is important to consider the issues of this in the health force to promote the good health force as well as the good health of the particularly the villagers or overall any.
Okay, a very good morning to all present. I'm Dr. Mamta Latwal, Associate Professor at the University of Petroleum and Energy Studies, UPES, Dehradun, India. And the title of my today's talk is Electro-analysis of clinically important drug paracetamol, a COVID-19 medicine. During the pandemic of COVID-19 and SARS coronavirus 2, fever was the most common symptom in the patients during the early stages. So paracetamol was taken as home treatment of early COVID-19 symptoms. So let us first understand chemically what is paracetamol. This is the structure of paracetamol. It is an aromatic compound. And we have seen paracetamol, we have taken paracetamol from the medical stores in the form of tablets for adults, and for kids, it is in the form of syrups. So it is the formula is C8H9NO2. Its IUPAC name is N4-hydroxyphenylacetamide. It is also known as N-acetyl para-aminophenol or acetaminophen. It is a non-opioid antipyretic and analgesic drug, commonly prescribed to relieve fever and pain. It can treat the conditions like headache, fever and cold, muscle ache, arthritis, backache, toothache. Now, the history of paracetamol. In 1877, scientist Herman Norfolk Morse, he synthesized paracetamol at Johns Hopkins University via the reduction of para-nitrophenol with tin in glacial acetic acid. Then in 1887, a clinical pharmacologist, Joseph von Mering, he tried paracetamol on humans, and it was used then as an analgesic and antipyretic drug. In 1893, he reported another derivative of aniline, phenacetin, which was similar to paracetamol. So then paracetamol was quickly discarded in favor of phenacetin, and the sales of phenacetin was established. But phenacetin was banned due to its analgesic abuse nephropathy. So paracetamol was first marketed in tablet form at United States in 1950, and the name of that drug was, that medicine was Trijesic. It was a combination of paracetamol, aspirin, and caffeine. In 1963, paracetamol was added to the British Pharmacopoeia, and then it was available worldwide in tablet form. But in June 2009, an FDA advisory committee recommended that the maximum single adult dose would be decreased from 1000 milligrams. Earlier it was from WHO, it was 100 milligrams per dose, but now it is 650 milligrams per dose to protect people from potential toxic effects. Now the dose. The dose of paracetamol is very important. WHO has recommended doses of paracetamol that is different for adults and for children, and it is according to the age and weight. So according to WHO, for adults, it should be 1 gram, that is 1000 milligrams per dose. But as I told you that in 2009, FDA recommended that it should be 650 milligram per dose for adults because it was harming a lot. So if more dose, that is overdose, is being taken of paracetamol, then paracetamol poisoning may cause. What is paracetamol poisoning? It can harm our liver disorders may happen, skin rashes, inflammation of the pancreas, or it may lead to hepatotoxicity or nephrotoxicity. Currently, paracetamol is blended with other medicines in the market. So do not take any medicine having paracetamol as one of the ingredients without consulting your doctor or pharmacist. Overdose of paracetamol leads to serious health problems. Most commonly, it injures our liver. While taking paracetamol, one should consult the doctor if you're alcohol addicted. I have emphasized here alcohol because alcohol with paracetamol causes alcoholic liver disorder faster than only alcohol can do. And if regularly you are taking slightly more dose of paracetamol for long term, then it can also cause death. Now let us understand what is the metabolism of paracetamol. Paracetamol, liver damage results not from paracetamol itself, but it is from one of its metabolite. This one, I hope you can see my cursor. The one which is in red color, NAPQI, this is the metabolite N-acetyl parabenzoquinone imine. It decreases the liver's glutathione and directly damages cells in the liver. See, paracetamol has these three metabolisms. First, it may have a glucuronidation. Second, it may have a sulfonation. Or third, if it combines with cytochrome P450 enzyme, then this enzyme converts approximately 5% of the paracetamol to a highly reactive intermediate metabolite, NAPQI. Under normal conditions, what happens? NAPQI is detoxified by conjugation with glutathione to form cysteine and mercapturic acid conjugates. In case of overdose of paracetamol, this one, sulfate and the glucuronide pathways, they become saturated, and more of the paracetamol is shunted to cytochrome P450 system to produce NAPQI. As a result, hepatocellular supplies of glutathione depleted, and the damage of glutathione is higher. The demand of glutathione is higher than it is regenerated. So therefore, this NAPQI remains in its toxic form in the liver, and it may lead to toxic reactions with proteins and nucleic acids and damage our liver and kidneys. Now, what are the symptoms of overdose? When this overdose happens, how we will came to know that it is being in overdose, it is taken in overdose. So the initial symptoms may be nausea, vomiting, sweating, stomach pain, or loss of appetite. But if it is damaging your liver, then the another symptoms may be dark urine, your skin may be yellowish, you may feel tiredness, or you may feel confusion. So these are the symptoms of overdose of paracetamol. It means the dose of paracetamol is very important. So if a patient is undergoing treatment from paracetamol, this analgesic and anti-inflammatory drug, then analgesic and antipyretic drug, then see, the detection of paracetamol in the body of a patient is very important. So there are several methods which are used these days. Traditional methods are spectrophotometry or HPLC. It may be titrimetry, or it may be chemiluminescence. These methods are applied to monitor the concentration of paracetamol in a patient's body during treatment of paracetamol drug. But there are few drawbacks of these methods. Like, these methods involve tedious procedure. It is very time consuming. They are very costly, like HPLC, spectrophotometry. They are high cost instruments, and they use excessive solvents. So I studied the electroanalytical methods. Here I'm discussing that the electroanalytical methods, which can, with the same sensitivity and low cost, these methods will give same limit of detection of paracetamol in a patient's serum or plasma. What are electroanalytical methods? These are a class of techniques in analytical chemistry which are used to study an analyte by measuring the potential and the current in an electrochemical cell containing the analyte. There are 4 major methods. First is potentiometry. Potentiometry measures the potential of a solution between 2 electrodes. One electrode is reference and another one being the indicator electrode, whose potential changes with the sample's composition. So the difference in potential between the 2 electrodes gives an assessment of the sample's composition. Second is amperometry. Amperometry is electric current is here analyzed. So here the current is measured as a function of time or electrode potential. Third is coulometry. In coulometry, it uses applied current or potential to convert the oxidation state of the analyte. And in these experiments, the total current passed is measured directly or indirectly to determine the total number of electrons passed. And that total number of electrons passed will indicate the concentration of the analyte. The fourth method is voltammetry method. Here, the applied or constant, the applied voltage is given and the cell's current is measured. So these are the 4 different types of electroanalytical methods which can be used to monitor the concentration of any drug. Now, why we should use electroanalytical techniques? See, these techniques are extremely simple. They are very sensitive. They require very short analysis time, low cost, and these are convenient and versatile to use. So for that, firstly understand what is electrooxidation of paracetamol. As I told you that paracetamol with the help of the cytochrome 450 P450 enzyme, it converts to N-acetyl para-benzoquinone imine. So since when it will convert to this compound, it will release these two electrons. So when it will release these electrons will be monitored as they will give the electric signal, and the concentration of paracetamol or concentration of this NAPQI will be monitored in a patient's body. So how it works now, see? It contains an electrochemical cell. This cell will contain 3 electrodes. One will be the reference electrodes. Its EMF will be, its potential will be known to us. And another is the counter electrode, which helps in the completion of the circuit. And third is the working electrode. Now, this working electrode is modified with some modifier. This modifier is some material which can sense the concentration of NAPQI in the electrolyte, this electrolyte system, because this electrolyte system will have the paracetamol concentration itself. So this concentration of paracetamol will be sensed by the modifier. So what happens then? This is chemically modified electrode. There is an electrode here, and this electrode is modified. This yellow colored is the modification, the material which is used for modification of the electrode, and that modifier will sense our analyte. Analyte is the paracetamol, or this is actually the NASQI. So what happens? This, when it is sensed by the modifier, then it will sense the signals, and the transducer will convert it into electrical signal. And depending upon the type of electroanalytical method, it can be obtained, the result can be obtained in the form of these graphs. So it can be a CV, that is cyclic voltammeter. It can be LSV, that is linear sweep voltammetry. It can be DPV, differential pulse voltammetry, square wave voltammetry, and impedance spectroscopy, anything. So these signals, the graphs which you are seeing, which you can see, these signals will tell us the concentration of NSAQI in the solution. The commonly used modification procedures are when we modify the electrode, we can do paste mixing. We can mix it with the help of a paste, which is simple operation, very stable. Or we can do drop casting. Drop casting is an inexpensive method. It just uses some solution in which the paste is mixed. So we can do drop casting, but the film is not uniform there. Another is electrodeposition, which is a cost-effective and time-saving technique. This is very good technique, but it requires a lot of handling. So if a person is good to handle electrodeposition of a material, then this is the best procedure. And last one is the electrochemical polymerization also. It only depends on the ease of synthesis, that is the functionalization. So these are the materials, various sensing materials, which can be used for determining paracetamol. These are the nanomaterials which can be used for electroanalytical techniques, which can detect paracetamol. So we can have zero-dimensional carbon dots, carbon nanotubes, graphene derivatives, metal organic frameworks can be there, metal oxide nanoparticles can be there, metal nanoparticles, or conductive polymers as well. This is a comparative chart. See, as I told you that earlier, or these days, we used to have HPLC or spectrophotometry for measuring the concentration of paracetamol in the patient's body. But if we go through these electroanalytical methods, these are the electroanalytical methods. So if we go through these electroanalytical methods, CPE, GCE, or these one, and if we compare it with the spectrophotometric method or HPLC method, you can see the limit of detection. It is nearly the same. Either we use it in tablet form, or we use the urine or blood plasma. So it means that the results of electroanalytical techniques, they also give the similar results. The sensitivity is same, and the method is very simple and easy. So the research is going on in synthesis of these materials, these modification materials and the methods, so that we can have a good material which can show reproducibility and sensitivity similar to the already existing methods like HPLC and spectrophotometry. These are the few papers which shows the sensing of this material, this paracetamol in the form of CV. This is the graph of CV. Another one, cyclic voltammetry. This is again a CV graph. So these are the different materials which are used for modification of the working electrode so that it can sense paracetamol. So it only depends on the type of material, how easily or how good limit of detection it will have, how sensitive it will be, and how reproducible the results will be. Now my work, we have developed same voltammetric sensor for paracetamol using nano copper hexacyanoferrate CNT, that is carbon nanotube, modified with glassy carbon electrode. So I have used transition metal hexacyanoferrates here because they are very good, excellent redox mediators. They have mixed valency. They have very good ionic conductivity, excellent magnetic properties, and they are insoluble in water, so easily can be deposited and have microporous structure. This picture is showing the synthesis of nano copper hexacyanoferrates, where the copper salt is mixed with hexacyanoferrate salt, and we get this material in the nano form. So this is very slow drop by drop, slow addition of the two solutions, mixing of two solutions, and finally we will get this material, the nanoparticles, in the precipitate form. Then the particles were filtered, they were washed, dried, crushed, and then sieved with mesh size 100. Then I follow a lot of characterization to know whether the material is correct or not, what is the elemental composition, what is the amount of water present, what are the functional groups, and what is the size. So from this CHNS, AS, and TGDTA analysis, I got to know this is the compound formula. This is a formula of the compound so formed, nanomaterial so formed. And this is the surface morphology, the shape of the surface, the shape of the material, which was little bit cubic and agglomerated. And from TAM, it confirmed that the particle size is 30 to 70 nanometers. These are the IR studies, which shows the functional groups present in the material. Now, the electrochemical studies, that how I conducted the electrochemical studies to sense paracetamol concentration. So I used this material, mixed it in acetone, then cast it on the surface of glassy carbon electrode. I used drop casting method for this purpose. And then acetone was evaporated. And this is a 3 electrode system in which this is the working electrode, which was coated by my material. So these 3 electrodes were platinum wire, which acted as counter electrode, silver chloride, which acted as a reference electrode, and the copper hexacyanoferrate, the modified GCE electrode, which worked as working electrode. So this is the CV graph, the cyclic voltammetric graph for the modified electrode. It does not contain paracetamol right now. It is only for the material. Now this one, then I used the optimize the electrolyte concentration and its type. And also as I mixed CNT, carbon nanotubes, in it, so that it will have a synergistic effect and sense the sensitivity of the solution, the sensitivity of the material will increase. And finally, I found this, the oxidation peak of paracetamol, this one at 380 millivolt. This one, right? So this is on increasing the concentration. This is for 10 micromolar, 15 micromolar, 20 micromolar, and 25 micromolar. As I increased the concentration of paracetamol in the spiked urine samples, the concentration, the peak also increases. So with the help of these peaks are the indication of the oxidation and reduction of the material. So with the help of these peaks, I get to know what is the concentration of paracetamol in the sample. So in conclusion, the considerable progress has been reported for electrochemical determination of paracetamol with enhanced selectivity and sensitivity as well. The electrode surfaces modified with non-carbon nanomaterials like some metal-based nanoparticles also, they exhibit excellent electrocatalytic properties towards paracetamol. Only the difference in size and shape affects the reproducibility. Despite the advantages of polymers, they are unstable, so they can't be used for modification. But the sensitivity and practical application of electrochemical paracetamol sensors can be further improved by putting more focus. The researchers should focus on the fabrication of nanocomposites by means of appropriate combination of different advanced materials, nanomaterials. And the method which I proposed here, my co-workers have done, this can be used as sensor for paracetamol drug in the pharmaceutical formulations. So these electroanalytical methods can be used to detect paracetamol in pharmaceutical formulations or in the
Talking about task sharing among healthcare providers. Is it the way forward for providing quality maternal and neonatal health service provision, which is a glaring need of most of the global population? I'm Dr. Tripti Sinha. I work in the Department of Obs and Gynae in Shri Krishna Medical College, Muzaffarpur in Bihar from India. Greetings from Bihar, which is the land of Lord Buddha. And Bihar has got a very rich cultural heritage. The Nalanda University, the temple, the Vishnu temple in Gaya, Vaishali, Buddhist stupas in Bihar. But it is a sobering thought for we in Bihar that despite such a rich heritage, we have not really reached very close to the Millennium Development Goal and the Sustainable Development Goals about which we are striving to attain. And that is the reason why I have chosen this topic. My presentation thread will run through the following issues: why I decided on my topic, what is task sharing, task shifting, the experience of this strategy in fields other than maternal and child health, and the experience, impact, and potential of task sharing shifting strategy in maternal and child health. Bihar is a very thickly populated state, and this population resides mainly in the rural areas with all its connotations of remoteness, poverty, deprivation from a lot of comforts of a healthy living. And the health delivery system, although it aims to provide to the last man, we still have got miles to go. We start from the tertiary, from the bottom up, we start with the health and wellness centers, going up to the primary health centers, the community health centers, the subdivisional hospitals, the district hospitals, and the tertiary centers, which are mainly the medical colleges. Despite this, there remains a mismatch between the healthcare needs and the health resources, especially healthcare providers, to cater to the aspirations and health needs of our population. Medical graduates and nursing personnel are overburdened because the health-related tasks range from those requiring highly specialized skills to those requiring less technical skills and training, and more of soft skills like counseling and providing health education to the masses. So as I said, the Millennium Development Goals 4 and 5, which the MDG 4 addresses the health of the children, and MDG 5 addresses the maternal health. And the Sustainable Development Goal 3, that also aims to provide good health and well-being. And that is the reason why we need to sit together and think how far we are from reaching this goalpost. As one of the previous speakers Dr. Pratibha has talked about the frontline workers, these two slides show the contribution of the frontline workers, ASHAs, when a pandemic, a nightmare like COVID-19 strikes, and their contribution to the fact that we have survived it has to be acknowledged. And that is one reason why task sharing and task shifting approach has once again taken center stage at many of the WHO forums. Now, whenever we talk about task sharing and task shifting, the question arises, what's the need? And the answer is the workforce crisis, which is faced by the health systems globally, especially in the low and middle income group countries. And why does this arise? This is because although we have lots of medical colleges existing and many more coming up, we still fail to train adequate number of skilled health workers. And worse still, those in these countries who do get trained, they unfortunately do not remain in the country of origin where they got trained and migrate to richer, greener pastures. There are so many reasons why this happens. The migration is because of the poor work conditions, poor benefit packages, more job satisfaction and recognition in other countries, and going by the world political scenario, the political socio-economic context do play a significant role in this migration of qualified, trained, quality health workers, especially the trained ones. So coming next to the definition of task sharing. Task sharing emphasizes a team-based collaborative approach where different healthcare professionals from allied streams in health delivery, they work together to deliver services to accomplish a clinical task. This does not actually add up to the health workforce. What really adds to the effective health workforce is the task shifting strategy, which the WHO in 2008 had defined as the rational, systematic redistribution of tasks amongst health workforce teams. Specific tasks are moved, where appropriate, from highly qualified health workers who have got so much to do and so little time to do, to health workers with shorter training and fewer qualifications in order to make more efficient use of available human resources for health. We are always in short supply of human resources and manpower. So task shifting has got a definite potential to expand the pool of human resources for health. We have the human beings, they need training, and they need to be deployed in the right places. It enhances uninterrupted delivery of certain healthcare services, but it's very important to realize that just adding to the numbers is not sufficient. At no cost should the health and the patient safety and the quality be compromised in any way. Another word for task shifting would be substitution or delegation from one cadre to the another, and even sometimes to the non-professionals, the community people who have got an interest in expanding health services. So collectively, the aims and goals of both task sharing and task shifting are the same. It is a strategy in health management. Nowadays, just knowing your subject matter in your medicine profession is not enough. You need to know how to be an efficient health management, which is the process of identifying and realizing not only the short, but also the long terms while solving a problem, so that we can make the optimum use of available resources, which of course, manpower is paramount. And having done this, if we do it successfully, what are the outcome measures? We improve the patient-safe survival strategy for healthcare organizations. The developed countries have already made inroads into this strategy, but we need to develop it further in the developing countries. And the benefits are, it reduces, if we start this task shifting venture, it reduces the need to scale up health workforce while more medical graduates get ready to take on their responsibilities closer to the community and the grassroots. These strategies can increase the number of services provided at a given quality and cost. And this I again underline. At no cost is the quality to be compromised and patient safety to be jeopardized. And although we will be talking about mainly about the maternal and child health, this has got great impact on the non-communicable diseases as well as chronic health problems and in emergency situations related to other disciplines of medicine. So what are the types? And this figure shows the cycle. Task shifting from doctors to nurses is very common. Specialist nurse doctors to non-physician clinicians, who are the general medical officers, and they shift very often because of the great patient overload. They shift certain tasks to the registered nurses and nurse midwives who are trained in many fields, and they have got the potential to have got a role and to train cadres below them in the form of nursing assistants and even community healthcare workers, so that they can be delegated certain tasks, thus lightening the burden of the nursing staff, but at the same time reaching the community with certain important tasks. We do not need technical skills, but do have a role in improving the health outcomes. And task shifting has also been advanced to the expert patients, like people living with HIV/AIDS, having grappled with their own condition. They are in a position to guide similar unfortunate people to take up their care. So you can see what in this matrix, how the task shifting can spread right down into the community. Task shifting is actually not a new thing, only we've defined it recently. It's been there since long time. Informal or unsupervised task sharing often occurs in rural and remote areas where mid-level clinicians and nurses perform procedures outside of the official and sometimes legal scopes of practice. The strategy was first developed as a strategy in context of the HIV/AIDS epidemic, which struck Africa. And as a result of the pitiable condition there, the shortage of the manpower, the dying humanity, the WHO and the US PEPFAR and UNAIDS developed global guidelines about task shifting sharing, what to shift, what task to shift, whom to shift. That was in 2008. So, reiterating again, the advantages of task shifting strategy. It is a solution to workforce crisis in health. Physicians, nurses, pharmacists, clinicians, health personnel, they decide which tasks can be taken upon by a cadre which previously was not actually doing it. And when qualified, certified personnel are not available, what happens to the community? Its needs remain. And in desperation, they go to approach traditional models of healthcare, which includes, unfortunately, quacks, who very often do more harm than good to the population. It improves this strategy of task shifting sharing. It has got cost effectiveness and efficiency and improves the efficiency. And when a lower cadre staff is entrusted with a responsibility, it motivates her or him that such a lot of trust has been, and that helps in improving her personality. And because we have got increased manpower, it enhances the coverage, access, and equity of the health services, even in remote areas where the qualified doctors and nurses may not, perhaps for various reasons, be available. but the local community population has got the potential to become health care providers. As I mentioned, maternal and child health is not the only field in which this strategy works. It has proved its worth in malaria, tuberculosis, in the integrated common childhood illnesses management, and recently, and the HIV/AIDS epidemic way back a couple of decades ago, and in the not too distant past, we had the nightmare of the COVID-19 pandemic. This case study in Uganda highlights what this strategy can do. In 2006, the HIV prevalence was 6%, and it was the most common cause of death across all ages. As this is the condition in many of the developing countries, qualified doctors and healthcare providers, especially HIV physicians, were very scarce. And so they had to adopt a strategy by which non-specialists, doctors, counselors, treatment supporters, people living with HIV and AIDS could contribute to the care of the HIV/AIDS infected people. And this care included prevention strategies, treatment strategies, the care and the rehabilitation and support of the affected population. Based on the experience of success, the National STI and the AIDS Control Program in Uganda, in order to see that standard treatment was given to all the affected population, they rolled out treatment guidelines to assist various levels of health workers to roll out ART, how to initiate it, how to follow up the patients, and so forth. And the results were so encouraging in the AIDS context that it led to an expansion of task-shifting sharing strategy in mental health programs and adolescent health programs as well. This paper is also from Africa, and this highlights, again, what I have been talking about. And this, again, is another paper from Highlight, which says that it's not only the maternal, but other neonatal conditions also, which can be handled as a result of this task-shifting, task-sharing strategy. And in the first paper, they reviewed the rationale of the and scope of the task-shifting strategy implementation in so many fields apart from HIV, which included conditions like drug readiness training, management of chronic conditions like hypertension, diabetes mellitus, and emergency management of obstetrics, obstetric and neonatal emergencies, family planning services, the post-abortion care, the tuberculosis DOTS treatment care, and even eye care, doing cataract surgery, etc. Now, this paper by Angela Dawson, this focuses mainly on the emergency treatment aspects in which task shifting and sharing strategy can be made use of. It concentrates mainly on obstetric surgery, anesthesia, and abortion tasks. But it does not really talk about how this task shifting and sharing strategy can be made use of in other non-emergency cases, aspects of maternal and child health. And importantly, this paper also deals with the numerous barriers that indicate that the health system services will have to overcome if task shifting and task sharing are to be proved fruitful. In this paper, Dawson concentrates on the tasks like emergency obstetric and neonatal care, abortion, contraceptive and family planning services, and antenatal care, including the prevention of maternal to maternal to child health transmission of HIV/AIDS. And the cadres to which the task shifting was done included non-specialist doctors, assistant doctors, midwives, nurses, auxiliary nurses, and community health workers. They are the frontline workers, which have the important role of bringing in the population who need the health services of specialists to the healthcare facility. And this is a very busy slide, and on the whole, it repeats what I have already talked about, the scope of the health of the task shifting initiative. This study had certain limitations in that it only reviewed literature published in English, and it was limited just to a 10-year period. And perhaps only the successful experiences about task shifting and sharing were talked about. And we may have cases in which it really did not prove that it was really useful for dealing with the health force number crisis. It focused only on emergency obstetric problems and surgical abortion rather than promotive and preventive health-related tasks, which are very closely related to maternal and child health. And hence, longitudinal studies were needed to provide evidence of the cumulative effect of task shifting and sharing on standard indicators of maternal and neonatal health. And then approaches to align, it did not really address the approaches to align training with assessment of the health professionals' performance at the workplace, and the regulation did not, it was not explored how these task shifting strategies could be regulated in any because of ineffective, so that the ineffective use of health workers could be handled. This study did take some inputs from the providers about their views about task shifting and sharing. They believe that although this strategy had a potential to reduce the workforce crisis, yet it was very important that the in-service training should be continued of those cadres who were newly initiated to perform certain tasks. And even after the training, hand-holding and supervision at the workplace was extremely important because it was adding to their workload. It was important that they should realize that in their new roles, they had further career progression pathways, and they should be offered incentive packages so that they have sustained interest in the newly delegated tasks. And it was also noted that there were certain barriers like poor staff coordination and preparedness. And because of the training, if the training was not adequate and efficient, the newly delegated tasks to the cadres, those cadres did not perform very skillfully. And very often, although they were delegated the task, it was found that they could not actually deliver that service to the population because of logistic problems like lack of equipment and drugs. And it was another thing that was noted, that there was resistance from the hierarchy at the upper end, lack of trust that a cadre which was previously not performing the task would be able to do it with the same level of efficiency that they were performing. And there must be so many reasons why there was a resistance from the higher order of health professionals. But there were solutions which needed to be that can be worked out, like efficient coordination for proper skill mix and teamwork working in a particular health facility. They can decide amongst themselves which tasks they can work together, which tasks they can be shifted to the less trained healthcare workers, and so on. And it is very important that in order to maintain the skills, refresher trainings and regular workshops was very important. And this has showed results in Nepal and Zambia, where regular trainings and continuing professional development sessions are held so that the skills are maintained. In order to facilitate the work of these new professionals who have been entrusted with new jobs, they can work more efficiently even after training is over, with the help of job aids, books, cards, using them as aids memories and clinical tools to enhance decision-making skills, simple algorithms which can be read by the understood and interpreted by the mid-level health workers like ANMs, so that when confronted with a particular problem, they can find a solution to it. And if they are not able to do that themselves, they always feel supported, that in the case of any difficulties, there is somebody at a higher level who can sort out the problem and train them further. So, although tasks may be shifted, it does not absolve those who were previously doing it of their responsibility of supervision. They need to regularly assess the learning needs and skills assessment and need to utilize skill assessment tools so that they can delegate their new tasks only after assessing that the person, that the cadre is really up to it to handle it. And this has been addressed. This issue of adequate supervision and monitoring and evaluation of the task shifting strategy at different workplaces has been facilitated by the WHO 2012 recommendations on how to support health workers at the workplace. And as with any initiative, it has to go through the audit cycle of clinical practice of the mid-level staff entrusted with additional responsibilities. And it needs to be improved, modified as and when needed. And very often, task shifting a particular role need not be a permanent thing. Once the need has been addressed, it may also be rolled back. This is another paper in task shifting in maternal and newborn health, key components from policy to implementation. Again, this talks about the levels to which clinical and other health-related tasks are shifted to. The community health workers, the nurses, these are the nurse midwives and the auxiliary nurse midwives and the general duty medical officers. These are the people who will need to receive these special skills so that they can address those issues which impact negatively upon health outcomes. Like in Afghanistan, they started, and also in Nepal, they started. PPH is a very common cause of maternal mortality, because very often because of home births. By the time after delivery, by the time the woman comes to the health center for management of the emergency, she comes in a irreversible stage of shock. This has been prevented by the strategy of the community-based distribution of misoprostol for PPH prevention. In Nepal, as in the community health workers, they do antenatal care of the woman, and at the 8th month of pregnancy, the pregnant women are given misoprostol tablets so that in the dire emergency that home birth occurs, she can take it right after birth, just minimizing the chances of postpartum hemorrhage. The previous slide was very busy. This box illustrates the maternal and newborn care tasks that may be shifted to different cadres in a very succinct manner. The lay health workers can help in malaria prevention, labor support as birth companions for the prevention of postpartum hemorrhage. They can help for the primary steps of neonatal resuscitation in the management of newborn sepsis if they are trained to recognize the early signs, and they can give the initial dose of antibiotics if maternal sepsis is being suspected, and the patient can be then referred straight to the health facility. All short-acting contraceptives plus and injectables can be distributed by the lay health workers. The auxiliary nurse midwives, in addition to the above duties, they can also help. They conduct labor and birth. They can start initial antibiotics in cases of threatened infection during labor. They can deliver basic emergency obstetric and neonatal care, and they can also insert intrauterine devices. And nurses who have a complete professional training, they, in addition to all the above, they can also perform interventions which previously was done only by doctors and best by the specialist doctors. Things like manual vacuum aspiration of pregnancies or incomplete abortions. They can also perform. In certain studies have gone so far to talk about cesarean deliveries being conducted by midwives and nurses, although there is a lot of disagreement upon how far they should go. And in addition to the other to these tasks, there have been certain studies in which non-specialists, clinicians and non-specialist physicians have done cesarean sections and even tubal ligation of women. In those cases, in those facilities where specialist obstetricians and gynecologists are not available. This paper is from the Japaigo group, who have shared their positive experience about task sharing and shifting in countries like Nigeria, Afghanistan, Nepal, and Uganda, and Rwanda. Again, the same tasks were mainly about which I have already talked. They have been studied by various various workers, and on the whole, they have been successful experiences, encouraging, which has these interventions started as a pilot study, but in many of the countries, they have been rolled out on a larger scale. What was found as a result of all these experiences, and most of these experiences about which I've been talking, they come mainly from the African countries, the Caribbean countries, and the Southeast Asian countries, where this issue of a sufficient number of qualified health personnel is a glaring gap in the health delivery system. And it has been found that community health workers can successfully do this task shifting initiative only if it has got support both from the health system as well as from the community. The community must be clear about which tasks they would like, they would appreciate. They would like the community health worker to perform. They should have, because they are important stakeholders, the selection of the community health workers is very much within the domain of the community leaders. And they found that enlisting the help of community health workers is important as far as accountability of the community health worker is concerned, and the motivation of the worker is also concerned, because he or she belongs to the same community. There is a greater sense of responsibility to deliver quality service in whatever task they have been entrusted. And the health system also needs to be geared to make this strategy successful. They have to, in a very rational manner, they have to work out what tasks can be safely and efficiently delegated to workers lower down the healthcare hierarchy. Training is very important, both the pre-service training, the in-service training. And as they become, these task shifting becomes more successful, there can be changes into the curriculum of the lower cadres, of the mid-level health providers, so that the curriculum gets modified to take on more roles as healthcare provider. Supervision needs to be continuous and rigorous, and there should be effective, robust evaluation monitoring, monitoring mechanisms, and there should be support from the government, both for the funding aspects as well as for the policy and platforms and the program directions. So coming to the Indian strategy to expand healthcare access, the National Health Mission, which initially started with the Rural Health Mission, the NRHM, which had an ambitious plan, the Janani Bal Suraksha Yojana, which typically is a strategy to enhance the access of the maternal and child health services to all women right down to the grassroots levels. And in order to, it was found that although there were community health centers at the periphery, these patients in the remote populations and the rural populations did not access this. So there came the role of the community health workers in the form of ASHAs, about which Dr. Pratibha has already spoken about. They were initially not given clinical tasks or part at all, but their main role in reducing the maternal mortality figures and even the morbidity figures and overall enhancing the high health outcome figures was that they served as a very useful bridge of bringing reluctant women to the healthcare facility so that they can have a facility institutional deliveries with all its connotations of safety to both the mother and child. The ANMs also were trained in further skills to like recognizing delayed labor, when to refer the patient from the primary health center to the higher centers in case they required abdominal delivery or other form of interventions which was outside their domains. And the Anganwadi workers, they also had a great role to play in improving the health of the children, so that, which is one of the reasons why women so often have big families. Now, this study, the CLIP trial, is a community-level intervention for preeclampsia and the which is one of the manifestations of the hypertensive disorders of pregnancy. Now, this was a global study, and one of the study centers was in India. This trial involved the serial measurement of blood pressure, and the risk, according to the blood pressure measurement, there was risk stratification. And if the woman was identified as high risk for hypertensive disorder, then the community health workers were empowered to start the life-saving therapies like oral antihypertensive and the intramuscular dose of magnesium sulfate, followed by immediate referral with the help of ambulance services to a health facility, higher health facility, where this emergency could be handled. Usually, in the beginning, it was found as a part of the study that there were certain concerns among the community leaders and the community and the families, that the community health workers like ANMs, etc., were not really competent enough to measure the blood pressure, to to identify women who were at risk. And so there was a lot of resistance, but with the involvement of different stakeholders in this venture, the community leaders, the family decision makers, and the women itself, in tandem with the health personnel working at the health facility and the district level higher officials, although they had certain reservations, but on the whole, they felt that it was not completely inappropriate that ASHAs could be trained to do home blood pressure monitoring, because very often the hypertensive disease of pregnancy go undetected, and the women fail to appear fail to attend for their routine antenatal care, as a result of which, when they finally go into complications like eclampsia, the case is already very complicated and contributes to the maternal mortality. Yes, definitely, there were certain issues relating to why blood pressure monitoring could not be done by the ASHAs, but all those issues were such that they could be handled, like the blood pressure instrument, which normally which they are used, they could become more user friendly, and they could be trained how to detect that the reading was not proper by having regular calibrations. And regarding the magnesium sulfate, it was only the intramuscular dose that had to be given, and as soon as the in parallel with the mag-sulf doses, it was it was mandatory for the ANM to not to linger with the patient at home, but to refer her to the nearest health facility, for which availability of transport and acceptability of referral was the responsibility of the higher health centers and the district administration to provide sufficient number of ambulance services. So the barriers, the lack of qualified manpower, need to scale up services, poor geographical accessibility, lack of administrative support, increased demand for the services and financial. Yes, they all were there. But despite that, it was found that with effective training, monitoring, hand-holding supervision, and incentives, there was scope that the intervention of task shifting with regards to hypertensive disease of pregnancy can yield favorable outcomes if ASHAs were properly trained to take blood pressure, do risk stratification, and refer the patients to the higher health facility after giving them magnesium sulfate. Maternal and child health can never be kept apart from family planning interventions. A small family will yield a healthy mother and fewer children who are healthier. As a result, the WHO and other organizations devoted to family planning and contraception have worked out policy briefs for the implementation of task sharing guidelines for long-acting and permanent methods. The oral contraceptives and other natural family planning methods have been done by lay health workers, but in the scope of the cadres, of these cadres in providing long-acting and permanent methods has also been enhanced. So the uppermost row shows those contraceptive services like informed choice counseling, the combined oral pills, the progestogen-only pills, the emergency contraceptive pills, the standard days calendar methods, the lactational amenorrhea methods, and condoms can be provided to the population, target population across the board, from the lay health workers right to the specialists. The problem was whether those interventions, like which involved surgery, could also be task shifted. So no, but it was definitely found that vasectomies, male sterilizations, and tubal sterilizations, which previously were done by specialists could be handed down, shifted to non-specialist doctors and physicians and clinical officers, but definitely not to the midwives and nurses. But having said that, there have been certain studies in certain countries where nurses with sufficient experience have also been entrusted with the duty, have been given the power to to do tubal sterilizations. Although I'm sure most of the doctors, the medical professionals, will have reservations, because sometimes this seemingly simple operation can become very problematic, and if it's being done in remote areas, it can have adverse impact upon the general acceptance of tubal ligation if even one case goes amiss. This again, this and the other and these slides again deal with the experience of providing IUDs, implants in different countries by different levels of the health workers who were previously not doing it, but now they have formed that they can do it. In relation to sterilization operations, although they are not supposed to be actually performing the operations, yet frontline workers and community health workers have a very important role to have got a very important role in increasing the uptake of sterilization, because they are very good counselors. So their role cannot be and need to be underscored in this respect in relation to female sterilization and also the male sterilization, because they can do very effective counseling and encourage patients to come up and accept this permanent method. So, as a sum up, the challenges remain. The quality of care and safety has to be paramount. It is not just that task shifting and sharing, if they appear to be cost effective, we can just roll it out. What is paramount is patient safety. So that is very important. And the challenges are how to assess the potential of the health workers, whether or not they are up to mark to accepting the newly entrusted tasks. Resource scarcity, mentorship, in-service training, support, supervision, all this is a long agenda, which includes to a lot extent funding and qualified technical support people. And as I mentioned before, because of the mindset of the higher level professionals, that resistance is always there and will perhaps take time before they also realize that task shifting is actually beneficial at both ends, because doing less of those skills which can easily be performed, those tasks which can easily be performed by less skilled and less trained people, the senior professionals will have more freed up time to improve the clinical care they give to their patients. Policy and regulatory environment may need to be modified, which again, especially the rules and the legal issues may face lots of resistance. Motivation, retention, and performance. You may shift tasks to the community health frontline workers, but if their morals are low, they feel less motivated, your training will go waste if they just leave the service altogether. And gaps in leadership, planning, monitoring, evaluation, ethical and legal concerns. So it is not just one issue which has to be handled. It is a multi-sectoral approach with the final cumulative effect that we are enhancing the accessibility and equity of the health manpower to reach the most remote and the rural populations. And this study came up with a very important point that although task sharing and shifting has been in place for so many years, there was actually a lack of a concept matrix on which to base these programs, these programs and policies. And this paper summarizes the strategy, the task sharing and the task shifting strategy. The definitions, first it handles the definitions about which I've already spoken. And it says that before you roll out a task shifting initiative, you have to first of all identify the opportunities. Opportunities range from diversifying the care options and the modes of delivering a particular service to the community, redistribution of responsibilities and within the workforce, which is going to be very beneficial for the highly professional, higher levels of the cadre, and deliver one thing. Although we may be very technically competent, yet counseling skills, it has been my own personal experience, is very often better in the lower level, in the lower cadres of the health service. And their main role that is that by using the counseling skills, they can deliver more culturally and contextually appropriate care in settings where highly trained workers either do not mingle with the community or the community itself has difficulty in interacting and understanding them. And there may be certain, in order to permit scale up of certain essential interventions, like, for instance, the provision of IUD. If we allow more of the health workers to insert IUDs, that is definitely going to impact upon the family planning take. And as I noted, one thing healthcare workers need to, across the board, need to understand that it is very important that you work as a team and change the conventional hierarchies, which is a invisible barrier in improving healthcare service in certain situations. Before we identify and work upon and roll out a task shifting initiative, it is very important that there are certain criteria. So these criteria are divided into the necessary conditions and the important considerations. For any task shifting initiative, it is very important that the new cadre of the healthcare provider who is supposed to do this new task, that cadre should be willing, and the existing providers should be willing to provide the necessary training. And the issue itself should be such that it is actually a felt and unmet need in the community, that accessibility to that service is poor, and therefore we need to have more workforce. And the intervention, it is important that this intervention should be possible with less training and should be really clinically effective. In addition to that, if there are sufficient resources, important resources, then we can scale it up with gradually
Hello,
in a
Dr.
short time.
Shakti. Sorry for interrupting your presentation. I think you have exceeded the time, Doctor. Please keep the times.
Yes, I will just. So the key messages to my audience is that the task sharing to a large extent effectively addresses the health workers shortage. Shifting any health-related task to lay persons and community entails a lot of responsibility to the policymakers, program managers, medical professionals, and all stakeholders. All initiative needs to be supervised, monitored, and evaluated and carried forward, modified, or wound up, depending on its outcome or future needs. And only then it will have a lasting impact upon the different aspects of healthcare.
Thank you for the organizer and everyone, involved into it, to make me a part of it, for giving this opportunity. Before I start, I just want to give a background. What made me to work in this area? Because it's like my mother is 82 years old and she's dementia patient, Alzheimer and Parkinson also with other, but this neuro problem has many complications. Before that, when she was normal, she got widow at the age of 40. So after that, since I've been with her and closely observing, so that made me feel that she should not feel lonely, right? So I used to talk to her, to tell her to meet with people and many things. But since everyone has its own temperament, and she was a kind of reserve. She used to feel that okay, she needs to be in a family, or we are of us, but we're not very demanding also. But as a concern, so at times, since I was in psychology, I took psychology and I was to different platform, I used to feel, why don't we have something like a play school for kids, like a something where the old people or the senior people, not very old, but senior people can go, an individual, they can get connected with their age group people, right? So that can be helpful for them, even if for a short duration. And I know there are many things, but so on and off, it used to make me feel. Then when it comes to doing a research, as I am a professor in Department of Psychology, Jamia Millia Islamia, New Delhi, India. So I get a chance to do a research, to supervise a research. So this area among older adults, because now she's 82 years old and many things are there. And I realized, and recently what happened, that she was admitted in the hospital and in ICU. It used to depend that how the nurse, it's a nursing care and related with the older people, patient care. So it's important to mention over here how it matters if a very caring connection is provided to the patient in the hospital, by in ICU, or by the healthcare professionals. And you know, these the nursing staff has an important role. And sometimes she used to not listen. And I got a special permission to go to her to make her that, okay, she can, they can feed something. That made me, that's how psychology has a strong role to play, how everything. So connection, how the significant connection is important. So, and WHO has declared the epidemic of so loneliness. So it all helped that, okay, let's work together with my research scholars and things. We are working in this area. So it's a brief work. I'll take care of the time frame also, that but this background was important, that it is coming from the heart, and I'll just want to share, and this is an international platform to everyone in this field, healthcare, how we need to make the patient, the people who need help, they need a psychological help also. They need to feel a belongingness, that okay, they are wanted, you know. So these things are important. Let's start. Loneliness and feeling of being wanted. Like this Mother Teresa, this quote is really very important, because it's very, very sad thing when somebody is feeling unwanted. That loneliness, it kills, you know. And it is said that it affects more than the smoking cigarette. So WHO identifies social isolation and loneliness, and that's how that every 1% among 4 older, and I'm focusing more on the older adult people, right? So they feel lonely, isolated. And by Center for Disease Control and Prevention, 50% are dementia patient, 32 get stroke, 29 coronary heart disease, and just social isolation is important factor which increases these disease. By 2050, the number of people aged 60 years and over will double to 2.1 billion globally. Just imagine how we are and where we are leading. This has also led WHO to designate 2021 to 2023 as Decade of Healthy Aging. In line with this, WHO is working with partners to address social isolation and loneliness as pressing public health and policy concern. Because, of course, the policy matter is there, because that's how it will be. And I'm happy people have started talking too much about it. So definitely, people who are working in this area, I have tried to take few of the things, but cannot capture all the people who are doing into this area, but definitely some to help and support my topic, what I want to, how we can foster some social connection, which can help loneliness, which can prevent also. So it's also for the preventive measures if we start from the young age, and that will be helpful. So developing guidance on how to implement and scale up effective intervention, improving research and strengthening, because this paper is based on review of literature. So this is of 2.5 years, and 58 papers have been reviewed to find out using reflexive thematic analysis by Bro and Clark as their guidelines. So it is, what I am sharing is based on research. But definitely my focus is more on how we can do it. So there are 3 prominent things, and one by one I'm going to share with you. Like social prescription, it's a holistic approach. Now, what is social prescription? It is an approach that connects people to activities, groups, and services in their community to meet the practical, social, and emotional needs that affect their health and well-being, act as a bridge between healthcare and social support, enhancing the traditional medical care model, National Health Service. So, you know what happened during the COVID? This was like, of course, a pandemic, which we have faced first time. And no, you cannot see people around and you are alone. So people who are alone and everyone and the social distancing. So I think at that time, there was a webinar, it was a need. And then I got to know about this social prescription and from the book of Dr. Vivek Murthy, US Surgeon General, who talked, and the book I'm still reading, which talks about many things, that how he used to deal, that it is more than a physical ailment. So the doctors have to think more beyond physical, where the psychological component and how he was prescribing the patient, and that was helpful. So it is the primary healthcare providers, then they go for link workers. So link worker here are the liaising people between the community where and the doctors. So that's how the link provider used to follow up with the patient and the community and voluntary sector who provide some support. And when it is a nursing and patient care, so it's like they can play a major role. They are really helping between the patient and between the doctors and the patient's family, and what can be done. So these things are important, that how it's proceed. Then regarding the prescription, there is the pictorial itself will be reflecting that it's about blue social prescribing and green social. I'm giving only brief, that the picture itself indicates blue is ocean, right? And how prescribing the older adult to get connected where with the sea, with the water, and that the people who live, who are privileged to be closer to the ocean, closer to the water, and something which is helpful for them, or canal, some of the countries, European countries, some of the rural areas, it really helps because nature has a soothing power. And then green prescribing is about the greenery, the plant, the many people who cannot go to reach because it's not possible everyone to go to the ocean, right? So but in a closed flat, plant can be a good health, a healing thing. So that can be promoted and that can be. Then the first I told about the prescription, social prescription. The second I am telling about the social scaffolding. It is enhancing social connection in aging communities. Now here, how the support system can help. So it is in a healthcare setting. Social scaffolding refers to the intentional creation of supportive framework or environments that facilitate social interaction, connection, and engagement among patient, caregivers, and healthcare professionals. It involves organizing and implementing activities, programs, and intervention designed to promote social interaction, emotional support, and a sense of community within the healthcare environment. So there are three under this social scaffolding: the peer support group, community center, and intergenerational. I'll just tell you one by one. So peer support groups, formation of small groups. As I told you in the beginning that I used to talk to people, why cannot we have a school, like a play school for the older people or for the people who are, who need to meet, who don't have, not sometimes due to various reasons, somebody's alone. Like this lady who has started this NGO, it's there who need an NGO to empower people over 50 to get out there and make new connections. Why cannot we have? And I'm so happy and glad that she's doing a a wonderful job, and people, they meet, they can get connected, and it's really helpful for all the people who feel lonely, because you even if you are in a family, but some of peer group who can understand your situation, right? There are very senior living wings are there now in modern cities where those who can afford can go, but not everyone. So, but there are people, they need some companionship. So this is a very good initiative. And if it can be spread more, if in a small way we can do regarding something where these people of that sort can be together, but definitely somebody needs to efficient. So policy maker can think about it. Then the community centers, and you'll be amazed to know that there is a village in Gujarat in India, Chandanki village, India. Not every house has a kitchen to cook, because they sit together, they cook, they eat together. So they have a platform where they get connected. It's a very good, like something, it's a community outreach where you feel connected with others. You need people. When you're doing collectively, you are bound to connect. You are bound to do certain things where even people who are reserved, they will they'll be talking about the responsibility which they have been given. So by circumstances, they are compelled to talk, to get connected. That will help them to prevent themselves from loneliness. Then the other initiative also in Assam startup, Aquali Care, is fostering gracefully aging. They're run by Sukanya and Debastuti Barwa. And I really salute these young girls. They are really doing a commendable job, because Mind Needs Foundation is doing it actually, which is very much needed. They started during the COVID, and how they felt, and how, because sometimes people, it's not that sometimes family does not want to, the members, but they have to do other things also. The responsibility of job and some other thing, they are far off. But something like this can make them feel wanted, and they can feel happy. Their well-being can be enhanced. Now, the third under the support system is intergenerational activities. This is about the good fellow. The initiative is taken by Shantanu Naidu, 30 India, who managed Ratan Tata's office. Ratan Tata is a business tycoon, everyone knows from generation, and they do philanthropic thing and something for in people who are in need. So what these year, because it has been found that many youngsters, they are alone, right? They feel lonely. And there are many older adults, they feel lonely. Why cannot we just make them together, connect them together? So this initiative is of that, making them, so these children, young children, they go, they volunteer themselves, they help them regarding the technology, how to get connected through the technology. They help them for the groceries. They help them to do some recreational activity and make them feel, it's like when you see, because I have shared the presentation, and there you can click and you can go and find how they make them feel like they are not actual the grandchildren, but they are more than that, because at that time of need they are there, so they are equally important, right? Okay, so the third is social technology, enhancing connection through technology. Now this is a tricky thing, because older adults, not everyone is of technology competent. So there, the linked worker or the people, we need to make something where those people, the youngster or something, can help them, that okay, they can share with the, some friendly app can be made, and they are in fact now, and it can be helpful for those who are able to. And I must say, it's not about illiterate or illiterate. The smartphone has made everyone to get connected, right? They can send their voice message, they can do. So it's like sharing their stories, community activity through technology. Then mental, and COVID has taught everyone, you know, those who were not very interested, COVID has compelled everyone. So now everyone is having knowledge of it or usage of it. So mental exercise and games, that how it can be helpful. Then companion app and group. Here it is, these adorable Japanese robots are being used for elder care. Dr. Lilian Hong, Canada Research Chair in Senior Care and Assistant Professor of Nursing at the University of British Columbia, is trying out two Japanese robots called Kiwi and Mango, which may have the ability to provide companionship for senior citizens in Canada, reducing their loneliness. So just see, it's a time we all need to actually start from our end also, because world is going towards a lonely and more of a older adult. So they should proceed gracefully, not feeling lonely, because by the time we reach there, we should have a good connection, which can help us. And you know, good connection, meaningful connection, which can, it's not only the numbers, it's about that meaningful, which can make you feel wanted, which can make you feel needed, you know, and that even a small connection can be a big therapy. Okay, so what is the takeaway for the healthcare workers? Now, this is the important in the last section of my presentation and session. So promote awareness. That's was my attempt. Now I am requesting you all to spread this. Screen for social need. In hospitals, it can be a screen out, like the way doctor diagnose the component, medical, physical. In the same way, if it can be a section, although there are sections in hospitals, but it can be section of loneliness, need people, social need. So that can be how it can be, and prescribed accordingly. Like somebody don't need more people, but need 1-2 people. Somebody might be needing many people to feel okay, that they are having surrounded by people. Somebody need a same age group. Somebody, although with my experience, I feel I have a very good friend She's a practicing clinical psychologist, retired professor, long time back. She's 88 plus years now, still. And let me tell you, because of her social connectedness, she has Dr. Shakuntala Dubey. It's Manobal is the name of her NGO or trust, which she does. She's helping many people, and she's an example. So there are many people who are doing a good, commendable job at their end, but we need more people in that. Then collaborate with community partners, that who all are there. Personalized recommendation, where when I was, this I already covered, because screen for social need already done. So how as per the requirement. And then communication training is also important. You know, I have observed, it's my personal experience also, that sometimes I understand there are so much of work pressure in the nursing. They have deadline, they have many things, and from one patient to other running, because medically giving them, attending. But I request those who have been smiling with making the patient that they are the family. I'm really salute those nursing staff, because in ICU, family is not there. But those nursing staff who are making, or healthcare professionals, the doctors who are making them feel wanted and to be heard, to listen, that they are there for them, is very important. And it's, it's important to convey through your gesture. Communication is both, verbal and non-verbal both. So if you do that, it will be a very good, you are doing, but those who need to improve can do much better, can contribute. The conclusion is that social connection is basic human need. Research shows that feeling of rejection or isolation are processed in the brain similarly to physical pain, highlighting the profound impact that social connection have on our overall health and well-being. Lieberman said that why our brains are wired to connect. And when we connect with people, it helps, increases the mental health and well-being. And the three key strategies of my presentation is social prescription, social scaffolding, social support. The three support: the peer, the community, and then intergeneration, then social technology. So as we have discussed about many of you have discussed about the physical ailment also, and medication and drugs also, we also need to take care of the social ailment to ensure a holistic approach to health and well-being. And I'll just share that, sometimes it's the doctors, Sigmund Freud, everyone knows, the physician, the neurologist turn into a big psychologist, psychoanalyst. It means there is the psychology component which can be more added into it and can cure much better also. Of course, doctors are doing, healthcare professionals are doing, but we need to do some more. The acknowledgement I want to give over here, thanks to the organizer, and especially Cezanne Frankina, the conference manager, because coordinating with many things and all the things. So, and my Bano Connection Lab team, LinkedIn, and special thanks to Inshaiman, my research students. They are very good. Because I talk to them, they are my support system. And they all are like Rakesh Srivastava, Mubashir, Tanushri, then Insha and Anam. And we work together, we discuss, and it's the outcome of it. And all the resources utilized in this presentation. I'll just share it's there on the PPT. The book is these books, please listen if you get a chance. It's not only for the people who are older, it's also for yourself also. With each book, I gain something. And there, as Dr. Juliana Hull said, that loneliness is like killing more than somebody who's a smoker, cigarette. So please, let's prevent ourselves, others, and the community, and let's do something for the older adults. Thank you so much for giving me this opportunity and my presentation. Okay, thank you.
Metabolic reprogramming and human health care. So what I want to speak about is that we need the different kinds of diets, different kinds of activities in terms of physical activities, social activity, and other activity. Now, all this affects the physiology of our health. Now, where is the problem is with regard to our disease, what can happen, like it can be cancer or gut dysbiosis or neurological problems. There can be altered metabolic functioning that the body might adapt. In relation to this, there may be the development of the microorganisms also, which will adopt altered metabolism. Now, if you want to counteract it, the easy way is revert back to the original metabolic pathway. Now, why it is a necessity? It is a necessity. Just a minute. It is a necessity because if you want to look at the human health, the health will be progressing with the normal metabolic pathway. Any kind of altered metabolic functioning is called as the metabolic reprogramming. Now here, what is the role of the nurses or other healthcare workers, anybody else? First requirement is look for how to feed the patient the right diet, or what you can say is the right food. Along with that, the first line of therapy should be practiced, that is administration of the medicines. So if you want to look for the health recovery, it need the first line of therapy plus well-balanced diet or nutrition. And together this, what it can lead to is the maintenance of metabolic flux. Now, how this metabolic flux can alter, it can be, say, for example, it can be studied in people with nutritional imbalances, undernourished, or economically weaker population. It can happen also in people who are overworking or who are overloaded. Now, why you need the health restoration? One is you need to know the molecular effect of the nutrition sources in metabolism as well as the metabolic flux. Like we can think about curcumin. Now, what all signaling pathways or how many physiological processes curcumin will lead to? That total process is not very clear. Why? Because what is the dosage that one cannot say. You can think in terms of medicine. The pure compound can be administered. But when you think of the common household, you will be intaking only the food weight, the turmeric. Now the question comes, how do you take, how much do you take? Because excess intake can lead to the health deterioration. Now, is it the only thing that is required to restore back the health? There are some more other requirements like the physical activity, social interactions. Now, club together of these two activities will help in restoring back health of person in cancer, neurological diseases, and gastrointestinal disturbances. So where do we rely on? nursing and other corresponding and associated professionals. For that, what is necessity to understand what is metabolism and metabolic reprogramming, as well as metabolic fluxes and alterations. So once this picture is clear, then one can think of, say, for any kind of first line of therapy or drug administration, how to restore back the health. So the work here is intended to highlight upon the importance of nutrition and how it can help in reprogramming the recovery of the patients from a diseased condition. So what is the importance of the topic? Physician and patient, this meeting between the physician and patient generates lots of questions about health problems, and many of these questions remain unanswered by the physician. So this leads to the generation of a knowledge gap, and there are many reasons wherein people may not work on these gaps. Now it is here, this knowledge of the metabolic fluxes, metabolic reprogramming is a necessity. Now, community nurses deliver the comprehensive care to the patients living outside hospitals, but still the process generates a lot of questions that need to be answered as priority in nursing and patient care. So one of the unanswered questions is that can humans regenerate their every tissue and the organs? And this is a very difficult question to answer. One possibility that can solve medical problems can be attempted as an alternative to this particular question. You know, what all this throws up the requirement. There is need for research, engagement, collaboration, funding, not only for the healthcare services, nursing, but also from the physicians, clinical information, system specialists. So it's essential now to look at the metabolic reprogramming. So metabolic reprogramming, if you try to look at metabolic activities, is essential for the life of a living organism, and this can lead either to the expenditure or consumption of energy. Any kind of disturbances in this activity can lead to the development of a diseased condition wherein cells adopt an altered metabolism called as the metabolic reprogramming. This is more studied in case of cancer as well in neurological diseases. So what you can say, it is a rewiring mechanism. Now this can affect the immune system functionality, so survival of a cell and its performing its physiological functions, and such condition is called as metabolic reprogramming. Now, if we try to look at the metabolic reprogramming, cells always will be under some danger signals. Like, I mean, the immune cell also, they undergo the metabolic reprogramming. You can have two situations. One is anti-inflammatory, the other is pro-inflammatory. So the consequence of the pro-inflammatory, it can lead to the tissue inflammation. Anti-inflammatory, it can lead to the tissue repair or immune resolution. There can be the crosstalks, and what we need to look at, there can be epigenetic reprogramming, and it can be again vice versa linked to the energy production and biosynthesis reprogramming. So human health, as defined by WHO, is a state of complete physical, mental, and social well-being of a person. So ideal meaning is there should be mere absence of a disease in person, right? We can say it as the person is healthy. The parameters to measure one's health is by evaluation of the ability in terms of physical, mental, social, and spiritual activity of the person, but with regard to their own defined environment. So health, in other words, refers the metabolic efficiency of an organism. Deterioration of their nature's health and ecosystems also affects the health of an individual. And that is in relation to the environmental deterioration, but can also affect the health of the person. The bad health can also due to the genes, heredity, lifestyle behavior, etc. So here the identified reasons for health issues are lack of physical habit, improper sleep, alcohol consumption, and environment. It can be also due to the aging, but can be again linked to the metabolic processes. So healthcare, if we try to look and provided by the professional healthcare workers, refers to the improvement of health by methods of prevention, diagnosis, and treatment for cure of a disease state. So robust healthcare system is essential to support a healthy society. Delivery of healthcare services is the timely use of a personal health services that can lead to the possible health outcome. So what all is necessary? The acquirement of adequate knowledge, the effect of dietary factors on the health of a person that can, it's probably lead to the health deterioration as well as restoration, so that the home people of the patients can also take the role of a caregiver. So provision of the primary health care is also essential to provide social justice, equity, solidarity, and participation. The present work is aimed to understand the metabolic reprogramming, its causes and effects, and advocacy of appropriate diet, nursing, and the patient care that can act as the therapy along with the standard healthcare practices. So what is the status of the healthcare system? If we try to look the patient, family, and community, they're dependent upon all the multiple factors: healthcare structure and process, health system improvement, value in healthcare, population, public, and social determinants of health, clinical informatics, health technology, healthcare structure and process, and healthcare policy and economics. So I'm switching over to the other figures. Now, if we try to look at the different healthcare sectors, we have the different components like biotechnology, competitive landscape, sector expenses, managed healthcare, sector sensitivity, key macro drivers, macro environment, life cycles, pharmaceuticals, distribution, equipment, and facility. We have also the other facilities like the national healthcare workers status in India as of 2008. And if you try to look at, work is in relation to the nurses or midwives. Then we have again the allopathic doctors, and followed by pharmacists, traditional medicine professionals, Ayush in terms of, and next health associates or allied. That's not applicable in terms of the figures, dentists, and followed by the total overall, what you can say, 5.76 million. Next, the schematic representation of the different kind of diseases. We have the physiological diseases, infectious diseases, non-communicable diseases, deficiency diseases, communicable diseases, health hereditary disease in terms of genetic and non-genetic. Size of the healthcare market in India. So if you try to look at this in relation from 2008 to 2020, if you try to look in, the curve is it's a rising curve, and if you try to look at the 22, it's almost giving a figure of 370 in terms of the billion US dollars. Now, in terms of metabolic reprogramming in healthcare, so the identified hallmarks of metabolic reprogramming at cellular level are enhanced level of glycolysis, lactic acid production and pentose phosphate pathway, mode of glutaminolysis, mitochondrial changes in enhanced lipid metabolism, altered amino acid metabolism, biosynthetic and bioenergetic pathways. So here there can be two categories: systemic reprogramming and local metabolic reprogramming. Systemic is associated with diabetes, inflammation, obesity, cancer, and liver disease. Local, it's associated with intestinal pathobiology, like colon cancer and inflammatory bowel disease. So metabolic reprogramming, it influences cellular organization through biomass and energy supply. So metabolic sensor regulates supply of nutrient availability and environmental changes according to this cellular condition. Now, this altered metabolic pathways affects the immune cell metabolism. It can affect also upregulated, what you can say, histone acetylation and suppress DNA methylation. So where all can be the resultant effects observed in atherosclerosis, chronic inflammation, enhanced infiltration of adaptive and innate immune cells in the arterial wall. This innate immune cells will lead to reprogramming of the metabolism upon microbial infection additionally, or maybe it's upon microbial infection, this immune cells can reprogram their metabolism. And in turn, what you can say, nutshell, this will benefit the pathogenesis of the microorganisms. So this reprogramming, it can affect organs like kidney. Kidney cells, this undergo metabolic reprogramming after injury, as well as in different kinds of diseases, and what can lead to the progression of prognosis of kidney disease. So pathogen infection, what you can say, it depends on the host proteinogenic amino acid metabolism, but gets altered, leading to an inhibition of the host immune metabolism. The alteration of the metabolic pathways upon bacterial infection, this can again simulate what you can say, Warburg effect. The Warburg effect is best understood in cancer cells. Again, if there is continuous drug intake, this can affect the gut microbial ecosystem and host metabolism. In turn, what you can say, this changes this in altered metabolism. This can serve as antecedent biomarkers of changed or a normal immune system function. So what is the way out? Reversal of the metabolic reprogramming. And this depends on the diet and nutrition. So way out, first thing is look for food bioactive components and cofactors like folic acid. Again, if we think in terms of dietary restriction without essential nutrient deficiency, is the other vital way to intervene upon metabolic reprogramming. Metabolic syndrome, it is the immediate postnatal life, and it results out due to altered nutrition experiences like undernutrition, overnutrition, and again, it can be due to modified milk formula. Efficiency of the cancer treatment, it can be increased by dietary interventions that affects nutrient availability in cancer cells. Again, calories restriction, this is also observed as a dietary intervention that reduces energy intake by approximately 15 to 30% while maintaining a balanced proportion of macronutrients and preventing malnutrition. So what is the effective strategy and management of cancer? This can be thought of as one effective strategy. Gut microbiota in pre-diabetics, this also changes with the dietary or the dietary patterns. The variations in the microbial profiles, it has been reported to result in infant neurodevelopment dysbiosis. So differential microbial flora has also been reported to be associated with cellular and molecular features of human immunity. In fact, if you think in terms of commensalism of the microorganisms within bacterial flora, this helps to fight infections, and commensals, again, in turn, can change on the basis of the diet. So what is the calorie value of the foods? We think in terms of alcohol, is 1 grams unit if consumed. Calorie, it gives 7 kilocalorie. Carbohydrates, 4 kilocalorie. Fat, 9. Protein, 4. Dietary fiber, 1.5 calories. Food in terms of some components like papaya, if you try to think, there are lots of the beneficial components like proteolytic enzymes, fiber component, short chain fatty acids, benefits, papain acids, breakdown of proteins, short chain fatty acids help improve the body's fiber consumption. So if curcumin, there's the curcumin. So it helps in management of exercise-induced muscle soreness, arthritis, hyperlipidemia, psoriasis symptoms. Moringa leaves, there are high levels of vitamins A and C, zinc, iron, calcium, magnesium, potassium, flavonoid. So diabetes, cancer, non-alcoholic liver disease, high blood pressure, high cholesterol. These are some of the diseases which can be, we think of the role reversal with consumption of the moringa leaves. Ginger, it can help in nausea, indigestion, common cold, anti-inflammation, pain relief. Licorice roots, it can act antiviral, antimicrobial. So there are lots of the food components which gives lots of the benefits. Beneficial components are known. If somebody is asking me what will be the signaling and in terms of what should be the dosage, how much dose should affect how much of this signaling, for that, the answer is very difficult to give in relation to the available knowledge. Now, if you try to think in terms of the glycemic index, there is a link between the foods and the glycemic index. Based on the glycemic index, we can say high GI foods and low GI foods. So what all comes over here? Brown rice, dairy products, legumes, here potatoes, white bread. So if you try to link it between these two, there's a strong association between glycemic index and risk of type 2 diabetes among individuals with a higher body mass index. So GI ranks the carbohydrate containing foods based on the body glucose response postprandial or after a meal. So what you can say in a nutshell, higher is the blood sugar reading, higher with the GI. In terms of the food guide pyramid for Indians, if you try to look in, bulk, if you try to look in energy-giving food, so here, how much it can be served, 6 to 11 servings. Production food, 3 to 5 servings, in terms of vegetables and fruits. Bodybuilding food, 2 to 3 servings. Meat, milk, yogurt, poultry, nuts, pulses, energy-giving food. Use very little in terms of fats, oils, and sugars. Physiological system, if you try to think, calorie burning is an essential requirement. So calorie burning means one needs to do the physical exercises, social activities also fits over here. Now, if you try to look at the picture, 1 pound of body fat stores roughly 3,500 calories. Extent of daily calorie burning for a sedentary woman is 600 calories, whereas the same for an active male is 2800 calories. Ideal calorie intake it depends on age and activity level of a person. So even though exercising on an empty stomach leads to calorie burn and weight loss, but it's not a suggested activity. Why? Because it is of utmost importance for a person to balance the calories for managing weight and calories consumed. When what will equal the calories expended, that helps a person to maintain the same body weight. If there is inadequate, excess, or imbalanced nutrition intake, this can lead to a state called as malnutrition. Malnutrition can lead to a person with underweight, overweight, or deficiency of specific nutrients. Now, the question comes in relation to the diagnosis. So in relation to the diagnosis, metabolic imaging is another option. The metabolic reprogramming can be linked to the metabolic imaging, and this has been practiced in terms of breast cancer therapeutic responses. Why? Because this practice can be used as a precise guidance to say about the usage of the anti-cancer drugs in cancer treatment. This imaging can be also used for treatment strategies in triple-negative breast cancer, where the spatial and temporal dynamics of the metabolic landscape are highly unstable. Metabolites, the state of the metabolites vary extremely. So critical challenges are involved with the analysis of data in medical imaging, including reproducibility and affects the fields like genomics. The screening for early cancer is one of the unanswered questions in medical imaging. And here there can be the biomarkers that can help in the adoption of the right therapeutic practice. So this can be linked to the metabolic reprogramming with the additionally with the metabolic imaging. So all this together can help in the timely diagnosis and treatment services that will affect the health of patient health status and healthcare service delivery. So to conclude upon, what you can say is the novel cancer therapeutics can develop with the understanding of metabolic reprogramming and epigenetic modifications that help in tumor proliferation. This understanding science of metabolic reprogramming, this will be of help to develop cancer precision medicine. It's not only observed in cancer, but also in T cells, in inflammatory disorders like the activation, differentiation, and trafficking mechanisms. So introduction and establishment of bacteria into the complex system needs understanding of the adaptive responses of bacteria for microbiome engineering approaches. This in relation to the gut microbiome, one can think of the consumption of probiotics or pro and the prebiotics, or like so examples. But where there is intake of the drugs, this can again help in remodeling of the gut microbiota. So here, the very good role of the caregivers vaccine to look for the diet so that the change of state between epithelial and mesenchymal phenotypes in cancer cells by MT and MET, this should not occur. Because if this occurs, these are essential for cancer invasion and metastasis, and this entire process depends on metabolic reprogramming. So the presence of mutation in FS genes and all these genes evidences that EMT and metabolic reprogramming are intertwined processes. There are the markers like mTOR and PI3K. So this can get altered, but you can say this can kill the cancer cells. Now, in relation to these markers, again, it works in relation to the question of the nutrition. So optimum nutrition refers to the intake of adequate vitamins and nutrients to support body physiological processes. So if we can understand this metabolic reprogramming, it can help us to revert back the situation of cancer as well as neuron dysfunctioning and in any other disease. So it will be also essential for the patient to undergo under supervision physical activity, social activity, and demanding the need for the professional caregivers. So these are the references. With this, I'd like to conclude upon and any kind of questions, I'd like to welcome.
I'm Ishal Liaquat, Principal at Alim Institute of Nursing, Gulab Devi Hospital, Lahore. And today my presentation topic is utilization of diverse educational methods in neonatal resuscitation skill learning among pediatric nurses in Lahore, Pakistan. This is the roadmap of my presentation. And now this is the introduction. The neonatal phase is the most critical period in the childhood, as majority of the deaths are reported in that period. Amazingly, the ratio is different among developing and developed countries. In developed countries, it is estimated as 3.7 per 1,000 live births, whereas in developing countries, the rate is 10 times more than the developed countries. Pakistan is ranked as number 3 on top 10 countries with the highest rate of neonatal deaths. The neonatal mortality rate in Pakistan is reported as 46 per 1,000 live births. Though there are many factors, however, birth asphyxia is the major cause, accounts for 1/4 deaths reported globally. There is an evidence that effective resuscitation measures can avert a substantial proportion of these deaths. However, health professionals, including both doctors and nurses, are inadequately prepared, specifically in developing countries. Nurses are our largest workforce, hence are found incompetent, specifically in the emergency provision of the care such as neonatal resuscitation. Mostly nursing education is based on the traditional methods, lacking adequate component of skill and training. The learn, see, practice, prove, do, maintain pedagogy is an evidence-based framework synthesizing after intensely reviewing the literature. It exposes the learner in two phases. One is cognitive, comprising 2 steps of learn and see, whereas the psychomotor phase dealing with the steps of practice, prove, do, and maintain the skill once attained. Thus, efficient in learning and retaining all the steps of skill that are necessary for effective learning and training. The educational methods have a great impact on learners' competency in clinical practice. In Pakistan, traditional methods are dominant in nursing education all over and are insufficient to impart practical knowledge among nurses. To the best of researcher knowledge, little published data is available at national and international level. Therefore, the current study has been designed to address the diverse strategies under the umbrella of pedagogical framework and compare its effectiveness with traditional methods to figure out which method is more instructive in nature. And here's a brief description of the literature. An experimental study was conducted by Raza and Mahboob among 80 nurses at Nishaba University of Medical Sciences. The study objective was to compare knowledge among two groups in which one is exposed to learning resuscitation through traditional method, while the other was exposed to high-fidelity simulation. This study reported significant difference in the simulation and traditional groups. Another study was a randomized controlled trial was conducted by Pinar et al. Among 46 nursing students in Anarka, Turkey. The study objective was to predict the efficacy of simulation-contained video learning in neonatal resuscitation education. A pre-post knowledge and skill assessment was done through validated questionnaire. And here, the study reported that significant difference was found in video-related group as compared to the control group. So, learn, see, practice, prove to maintain pedagogy to those who had learned through the two-step traditional method. And the hypothesis was there was no difference in skill among pediatric nurses learning of resuscitation through LSPPDM pedagogy compared to those who had learned through the traditional method. And here is a operational definition of the skill, which is the ability to perform resuscitation and neonatal resuscitation with competency in each step according to each scenario. And it is measured through a 30-item checklist for measuring neonatal resuscitation skill. The total score range from 0 to 30. And each participant was graded as unsatisfactory, satisfactory, and having good skill. The study design was a single blind randomized controlled trial and was prospectively registered at Clinical Trials Gov with NCT number 04748341. The setting was the nursing department of Allama Iqbal Medical College, Lahore, Pakistan. Duration of the calculated sample size was 24, and this size was small to perform the statistical tests with good efficacy. So 30 in each group were taken. And after adding a 20% dropout rate, the final sample size was 72, 36 in each group. The study included those willing to attend the full course, those willing to give informed consent and had age 18 to 25 years, while the study excluded those who were on leave from that period, had already received any educational training on neonatal resuscitation, and who are not involved in direct patient care, such as head nurses and nursing superintendents. The group A learned by the two-step traditional method that included one didactic lecture per week for 10 weeks, leading towards the second step of one skill session per week for 1 hour under instructor supervision, while the group B, following the stages of learn, see, practice, prove, do, and maintain phases of learning that included didactic lectures, videos, clinical observations, and 2 skill sessions for 1 hour. And this is the diagrammatical presentation of the difference between the two interventions. You can see that the traditional group was learned through only 2 steps, which included didactic lectures of 12 hours and skill sessions of 6 hours. While the group B was learned through the didactic lectures of 12 hours, including a video of 30 minutes, practice sessions of 6 hours, and evaluate through the checklist. Then 1 day clinical per week, total 36 hours clinical has been provided, and 1 hour skill session, which included the self-directed learning sessions for 6 hours. This study, including all the ethical considerations, written informed consent was taken from all the participants. Participants were remained anonymous throughout the study. The subjects were informed that there are no disadvantage or risk to the procedure of the study. The potential benefits and risks were already distributed to the student participants. They were also informed that they are free to withdraw at any time during the process of the study. The study participants were recruited through the process of simple random sampling. Initially, 62 participants, 31 in each group, meet the inclusion criteria. And further 2 participants were dropped in the follow-up stage, and hence yielding a total sample size of 60 participants with 30 in each group. The nurses allocated from each professional equally in Group A and B through the lottery method. Allocation of participants was considered using the envelope method. The assessors remained uninformed regarding the participation and the allocation status and the sequence of the scenario in the pre and post assessment. The data was collected at 2 points in time. First time data was collected as a pre-test before the educational intervention. And the second time data was collected after 16 weeks of educational intervention. 2 facilitator evaluators were trained regarding the scoring of each student in a 2-hour workshop before data collection. On the day of evaluation, nurses were divided into pairs. Each pair performed in 2 scenarios in which one was acting as a pregnant lady and the other was the helper and vice versa. All the simulation scenarios were performed in a simulated delivery room situation. 2 facilitators, one was acting like a pregnant lady while the other performing the role of a delivery nurse and presenting this scenario in a standardized fashion to each participant. And these are the 4 simulation scenarios on which student assessment was based in the pre and post assessment. Newborn scenarios were added for the maximum exposure of the nurses to all the steps of resuscitation. A maximum time of 10 minutes was allocated to all the participants to perform all the steps of resuscitation. A lab assistant was making a video recording to validate the observation and scoring. Both assessors simultaneously scored each participant. Any discrepancy was resolved through discussion and reviewing the video at the same time. Here are the results. As you can see, both groups A and B were found homogeneous in age, marital status, residential area, resuscitation exposure. As results showed that there is no significant difference in Group A and Group B regarding the demographic characteristics of age, marital status, residential area, and previous neonatal resuscitation exposure. This table showed that pre and post knowledge, skill, and self-efficacy score in Group A, and the results indicated that there was a significant change in knowledge, skill, and self-efficacy score after intervention in Group A. And similarly, the Group B, there was a significant change in the knowledge, skill, and self-efficacy score after intervention in Group B. Here, the results showed that both groups A and B learned a lot after the intervention, and there was a significant change was found after intervention in both groups. And this table showed the pre-education mean knowledge, skill, and self-efficacy score between both groups. And the results showed that there is no significant difference in knowledge, skill, and self-efficacy was found before education, as p-value is reported as 0.946 for knowledge, as 0.821 for skill score, and 0.983 for self-efficacy score, which showed that the results are insignificant. The post-education mean knowledge, skill, and self-efficacy score between both groups was showed in this table, and the mean change in knowledge skill score was significantly higher in group B, as the p-value is less than 0.001 as compared to knowledge and skill score. However, the mean self-efficacy level was almost same in both groups. So here the results showed that the group B that was learned through the pedagogical framework have more knowledge and skill as compared to the traditional method group A. Discussion. The study cohort was found homogeneous in general and resuscitation-related characteristics, and this is evident in previous randomized controlled trials on resuscitation among nursing students. The study demonstrated that the post-mean difference in knowledge score was significantly higher in Group B compared to Group A. The results are in the same line with an international study utilized the LSPPTM pedagogy. The study reported an increase in average knowledge score of residents to 76.1%. While contrary to this study, a previous study conducted by Kim and Ohan reported insignificant difference in knowledge among nursing students, and this may be this difference may be due to some geographical changes, and maybe there is a difference in the educational intervention. Another major finding of the study was that the post-mean difference in skill was significantly higher in Group B compared to Group A. The results are corroborated with findings by Singhal et al. Reported significant gain at cognitive and technical skill level with an increase in self-efficacy among participants after intervention. The significant effect of six-step LSPPTM pedagogy in front studies attributed to many factors. One difference was the addition of diverse strategies, and the other difference in contact time. As the group B has exposure to multiple times in the context of video, in the context of clinical, and in the context of self-directed learning sessions. While the traditional method group has only 2 times interaction in case of lecture and practice. And the results are supported by Drake et al. And who agreed that repeated exposure to learning interventions improve knowledge and skill among participants. So the study concluded that the LSPPTM pedagogy was found more efficient in enhancing skill in neonatal resuscitation compared to the traditional method, as a significant positive effect was observed in context with the skill of pediatric nurses after the intervention. Limitations, as it was a single center study including only female nurses. The do phase is modified due to the sensitivity of the topic and the ethical consideration. The skill was assessed in a simulated delivery room situation, and assessment of competency in actual clinical situation may vary and challenging. Lastly, the outcome variables were assessed soon after education, so we are unable to assess the retaining effect of the intervention. So here are a few recommendations for future trials. Should be recommended with a large sample size and multi-center study. This study should be recommended in a diverse group of health professionals in the actual clinical setting for a more actual assessment. The efficacy of LSPPTM could be tested in learning of the psychomotor skills in nursing education. Moreover, the long-term retention effect after 3 to 6 months should be estimated of for real efficacy and should be warranted. And here's are the references of this research article. Thank you for your patience and welcome any suggestions and questions. Thank you.
I'm working in Saudi Arabia, specifically in Riyadh, in King Faisal Specialist Hospital. And my work involves as a care coordinator, discharging patients, reviewing patients, and assessing patients for the discharge plan. So my title for today is Revolutionizing Inpatient Focusing on Medicine, Medical Service Department by Creating Multi-Collaborative Framework achieving strategic objectives in King Faisal Hospital Research Center, Riyadh, Saudi Arabia. My abstract, to give you a brief context, Department of Medicine play a pivotal role in providing support in pursuit and improve of operational efficiency, enabled to provide access to those who need the service as one of the objectives directed to priorities and efforts to align with the hospital strategic objectives. For that effort, we are focusing on the key performance indicators, such as decreased average length of stay, discharging patient midday, facilitating patients transfer to other healthcare facilities, because we have short-term program and long-term program according to allowable time frame of patients transfer. Hence, will create a pathway towards patient experience to their families as well as patients. Fourth, achieving efficient, effective care and provide optimal service to the said families. To give you a brief context as well, of Department of Medicine is one of the most largest clinical departments with an annual admission rate of 1,500 patients. We provide high quality care to patients right from their admission until their discharge. Our service include as follows. We have gastroenterology, endoscopic procedures, nephrology, pulmonary medicine, critical care medicine, endocrinology, infectious diseases, and dermatology. For that matter, the department has made invaluable contributions towards clinical care, education, research, and is determined to take a more proactive role in fostering the changes happening in the organization. For objectives for my presentation for this afternoon is as follows. For patient care master and specific clinical intervention in liaison of the length of stay, which was mentioned earlier from the previous presenter, streaming the frequent diseases under medicine, specifically internal medicine being admitted in emergency room, and to have a clear and appropriate goals of care by the medical teams to foster reliability. The first thing we did was we have an initial meeting with a multidisciplinary team, and we identified issues and concerns as follows. We have the length of stay, the expected discharge date, issues concerning orders or procedures requests which were delayed, and identified the time that the patient was admitted for emergency room. And this was called attention with the people concerned, like the section head of medicine, the radiology department, and as well as us, the clinical care coordinator, who would identify and review this patient accordingly from the time that they're admitted in the inpatient area. Moving forward, we also have the multidisciplinary team, which was initiated by the operational efficiency team in order to identify issues, particularly on that particular week, and to properly assess and evaluate and escalate issues accordingly. We have created an action plan for 6-month evaluation, which was a 17 action plan that we created accordingly with the team. We have the daily review of patient population, status per unit, and medical service. Just to let you know, there are 2 clinical care coordinators covering the medicine department with a 60-bed capacity. And one of the roles is that we review patients accordingly from the time that they are admitted in the patient unit, from emergency room, and to create a plan accordingly when they came about, like when they came about from home or referral from another hospital, or they're gonna be followed by under home health care. Another thing is that we identify pending diagnostic tests, which I have mentioned earlier, if needs to be expedited to have a final diagnosis and findings for these patients. We also have to review patients accordingly for admission by the medical team if needed to be admitted for inpatient units. So from the point of entry from emergency room, we have a core of medical team from medical department. They review patients accordingly if this patient needs to be admitted in the inpatient area or to be discharged from emergency room. or to be referred accordingly to the designated care, what you call this, short-term program by the hospital. We also practice escalation process with the involvement of the chairman of medicine. Just to let you know, the chairman of medicine is fully aware of the issues and concerns that we presented previously so that we can maintain and appropriately upon the issues presented. We also utilize external facilities as part of outside resources of the hospital being provided. We have the short term, in which we can provide 14-day resource for the patients with undergoing IV medication completion or waiting for like a family member to pick up them up. We also have a long-term program in which nursing care is addressed so that they are not under active management, and those kinds of beds can be utilized or admitted from emergency room. We also track patients accordingly on the length of stay about 20 days. We need to know the reason why these patients are admitted in inpatient room, and we can address accordingly. Is a patient needed to be admitted in ICU? Is a patient needed to be referred to other services? Or there's an extent of medical concern for other services? The number of patients being referred to other medical service because of change of medical service. We have also patients or medical services that needs to be referred under non-under medical medicine, as long as like surgery or under gastro, whatever it is. And we also have encountered difficult discharge patients who refuse to be discharged accordingly. So these are the things that we need to escalate upon with the designated team. Monitoring elective admission if they need to be referred to inpatient, like infusion center, the medical unit, and appointments in the clinic for follow-up and for results. And also we have also ongoing orientation every 6 weeks for incoming residents. As I mentioned earlier, we have also multidisciplinary meeting with all medical services under medicine, and staffing was also increased accordingly with the high complexity units, like 2 respiratory therapists was assigned, 1 ecotech, peak days of pharmacists, manpower to be increased for discharge medication to be expedited, 2 clinical care coordinator assigned with 60 patient ratio, and of course we have 4 case manager and 2 social services. We also have the implementation of the power plan. We call it care plan because we are now using Citrix, ISIS controlled, and this project has been initiated by the Department of Medicine and Care Coordination myself. So the reason why we wanted to have a streamline of patients being admitted in the emergency room, the primary reason for that, example, UTI, so they can do like a tick system, and directly the activation of orders can be done from emergency room down to the inpatient area. And this also would ease the manual adding of the most frequent diagnostic tests like CBC or the usual stuff that they need like renal profile, and it can be under the medical service of internal medicine. And this also impacted the length of stay on the expected timeline. And this also defined a medical assessment and evaluation on the fundamental framework of clinical recommendation adhere upon. I'm showing you a distinct statistics on year 2022, and you can see how it is that we had an 88 margin line on patients being discharged less than 9 days and 15% of being discharged of longer than 8 days. These kinds of patients, precisely, they have comorbidities. They're coming from ICU or they're being referred from other medical services. Also, we have maintained that on the year 2023, we have also a maximum discharges of less than 9 days of 88 to 90% and 10% for the longer 8 days and above. And you could see the longer days patient exceeded of 2023 because of the comorbidities of this patient, and most of the patients are really sick and needs referral. For this quarter, we had maintained of 209 patients for January, of patients being discharged of less than 9 days, and 178 patients being discharged for less than 9 days in March, 182 as well as in April. So we only have a 333 mark, which is like 15 to 20% of patients being stayed of longer than 8 days. We have projects in progress from the inpatient unit. We have the golden patient. How do we define golden patient? Whereas a patient is identified from the medical services, focusing on internal medicine as the medical service, as the patient population is higher and discharge planning has to be done accordingly from the time they're admitted in the patient area. Discharge checklist has been initiated by the nursing department to create a tick system to identify the needs of the patient of the time of admission and leading towards discharge planning through online ASHAs. And we have ongoing educational program for the incoming resident because the rotation of residents is every 30 days. So we have to go aboard with that. All medical terms currently assigned to all units thus be educated, informed about the in-house resources and referral to external facility of resources we have in the hospital.
My presentation is about the effect of factor characteristics on primary teachers and health visitors' perceptions about the obstacles in sex education teaching. The presentation structure includes the purpose of research, methodology, research questions, and the research instrument, the sample characteristics, the results, and conclusive suggestions. I will start with a brief overview of sex education and the barriers to effectively teaching in schools. Comprehensive sex education became part of most school curricula worldwide as the benefits it provides to students' sexual health are scientifically proven. The integration of health education into curricula from a very early age is important as it has positive effects on issues such as sexual abuse, building healthy relationships, developing skills, and others. A wealth of research indicates that the competence, professional development, specific skills, perceptions, attitudes, and abilities of educators are vital for the success of any sex education program. A complex of internal and external factors influence teachers' ability and health visitors also to teach sex education effectively. This includes inadequate training in teaching the subject, lack of confidence, lack of knowledge, sense of shame, social taboos, limited time, fear of parental opinion, inadequate financial resource, lack of support, and others. So, recognizing the importance of the role of the trainer in the effectiveness of sex education, we wanted to investigate the barriers encountered by both primary education teachers and health visitors in Cyprus when teaching sex education. Therefore, the purpose of this study is to investigate the impact of sample characteristics on perception of obstacles encountered during sex education teaching. The research questions asked to explore the sample perceptions on the barriers they encounter in teaching sex education are: the first one, what are the perceptions of the sample about the obstacles in teaching sex education? And the second question was, what do the following factors, gender, years of service, education, profession, and experience in teaching sex education, influence the perception of the sample about the obstacles encountered in the teaching of sex education? And the third one was, how do the following factors, knowledge, skills, personal comfort, abilities, and acceptance and perceptions like acceptance of diversity correlated with the sample perceptions of the obstacles encountered in the teaching of sex education? The research tool used was a semi-structured questionnaire. For the statistical analysis of the data, the statistical data analysis package SPSS version 22 was used. For the sample characteristics, frequency analysis was used. For the first research questions, frequency analysis was used too. For the second research question, 2 by 3 by 3 triple factorial ANOVA analysis was used. And for the third research question, correlation analysis was used. The questionnaire consists of 9 main categories of questions and additionally some other questions. For the present study, there is a category of questions about obstacles encountered in teaching sex education. The survey sample consists of 1,157 participants. The sample was randomly selected. Specifically, stratified random sampling was used to select school by province. The province of Cyprus were considered as strata, and initially a draw was made in each province on which school each health visitor would visit to collect the data. Depending on which schools were drawn, health visitors distributed questionnaires to teachers to 83 schools in all provinces of Cyprus. The largest proportion of the sample is female, 85%, which is due to the fact that most of the teachers and health visitors working in the public sector are women. As shown in this graph, the majority of the sample are primary teachers with a percentage of 92.2%. Health visitors make up only 7% of the sample, corresponding to 90 persons. This is due to the fact that the total number of health visitors nationwide is only 120. For your information, I would like to say that the health visitors provide, among other services, sex education programs in all public and private primary and secondary schools in Cyprus. In terms of age now, the largest percentage of the sample belongs to the age group 31 to 40 years, 42.9% corresponding to 496 people. This is followed by the 41 to 50 age group, 40.7% corresponding to 472 persons. The over 50 age group, 11.6% corresponding to 134 people. And finally, the 25 to 30 age group, 4.7% corresponding to 55 people. According to the findings presented in this graph, the majority of the sample reports that they had no pre-service and in-service training for sex education, respectively. In terms of experience in teaching sex education, the majority of sample, 74.4, corresponding to 862 persons, had never taught sex education. Interestingly, the majority of teachers, 60.7%, report that they have not received in-service training, in contrast to the majority of health visitors, 70%, who report that they have received in-service training on the topic. In terms of experience in teaching sex education, the majority of the sample had not taught sex education. 74.4% had not taught sex education. As expected, the majority of teachers reported not having taught sex education, as opposed to the majority of health visitors, 97.7%, who reported having taught the subject. The first research question was what are the perceptions of the sample about the obstacles in teaching sexual education? The category of statements consists of 7 statements like lack of teaching time, reduced self-confidence, taboos, inadequate training, reaction of parents, outdated education system, and extreme religious beliefs. And the sample was asked to answer whether they always, sometimes, or never encounter these obstacles. Based on the data analysis, it was revealed that the majority of the sample faces obstacles in teaching sex education. As evidenced by the frequency analysis, there's a consensus in the responses of sample regarding the obstacles encountered in teaching sex education. The lack of teaching time at 74.9% was reported as the most common obstacle encountered by the sample when teaching sex education. This is followed by reduced self-confidence comfort, 70.6%, inadequate training, 68.4%, and taboos, 64.9%. The second research question was, how do the demographic characteristics, gender, years of service, education, profession, and experience influence in the perception of the sample about sex education? The study explored whether demographic characteristics influence their perceptions of obstacles encountered in teaching sex education. This table presents the statistical findings resulting from triple factorial ANOVA among the participants. The independent variables were age, gender, and profession, while the independent variable was the perception of educators of sample regarding obstacles encountered in teaching sex education. As shown in this table, there was no statistically significant interaction among the 3 variables, age, gender, and profession, in the perceptions, and furthermore, individually, these 3 variables do not significantly influence the perception of sample regarding obstacles encountered in teaching sex education. Also, this table, the statistical findings resulting from applying a triple factorial ANOVA again, the independent variables were years of service, education, and experience in teaching sexual education, while the dependent variable was the perceptions of educators and health visitors regarding obstacles encountered in teaching the subject. As shown in the findings of the table, there was no statistically significant interaction among the 3 variables in the participants' perceptions of obstacles. The same held true for the effects of the variables years of service and education. Conversely, experience in teaching sex education had a statistically significant impact on the perception of educators and health visitors regarding obstacles encountered in teaching sex education. The research question 3, it was about how do the characteristics of trained correlated with the sample perceptions of the obstacles encountered in the teaching of sex education. The category of statements concerning the characteristics of the trainer consists of 8 statements, like knowledge of medical and biological issues, knowledge about the psychosexual development of children, knowledge from international experience on the subject of sex education, ability to use new technologies, training to use new teaching approaches, personal comfort, acceptance of diversity, and communication skills. And the sample was asked to answer where the belief is not so important, and very important. So based on these findings, correlations were explored. Specifically, it was investigated whether there is statistically significant correlation of sex educator characteristics on the sample perception of sex education. the relationship and the type of the relationship between the sample perceptions of sex educators' knowledge and skill was examined. The relationship between these two is positive, but statistically insignificant. Therefore, the degree of knowledge, skills, abilities, personal comfort, and perception of sex education does not seem to influence their perception of this factor. So, what are the conclusions drawn from this study? One of the findings of this study is that the most significant barrier to teaching sex education is lack of teaching time. This result is consistent with the findings of international studies that cite lack of teaching time as one of the most common barriers encountered by sex education teachers. Furthermore, the survey findings of reduced confidence and inadequate education were the most common barriers encountered by the sample when teaching the topic. This result is consistent with the findings of international studies, which report that these two barriers are among the most important obstacles to teaching sex education. Furthermore, taboos were mentioned by the sample as one of the most frequent barriers in teaching sex education. This specific finding is in line with several research findings that indicate that teaching sex education can conflict with the cultural values of the teachers, cultural taboos. Regarding experience in teaching sex education, which had a statistically significant effect on the sample perceptions of the barriers they encounter when teaching sex education, it should be mentioned that it is scientifically documented that experience in teaching the subject, along with other factors, like support, training, existence of a clear policy, increases teacher and health visitors' confidence and thus their effectiveness. Therefore, it is found that increased confidence and experience in teaching sex education help educators to deal with the problems they encounter more easily. So, the recommendation that emerges from this study is the urgent need for pre-service and in-service training of primary school teachers and health visitors in sex education. According to the findings of this survey, the majority of sample report that they did not have sufficient pre-service and in-service training. The findings of the survey show that the more confident the sample is, the more positive their perception of sex education are. So, the research hypothesis that inadequate education negatively affects most of the sample perception of sex education seems to be borne out by the findings of the present study, since taboos of educators, which seem to be barriers for effective implementation of sex education programs, are often rooted in ignorance. In conclusion, the provision of pre-service and ongoing in-service training will contribute to the effectiveness of sex education programs. Thank you for your attention, and I'm available for any questions you might have.
I'm Dr. Mustafa from Morocco. Workplace violence is a serious issue impacting healthcare professionals worldwide, including in Morocco. Today, I will share findings from in-depth analysis we conducted on this topic in hospitals across the northern region of Morocco. This presentation will be with an introduction defining workplace violence and outlining the aims of our study. I will then detail the methodology employed before presenting and discussing the key results. Finally, I will conclude by highlighting the importance of this work. Workplace violence encompasses both physical and non-physical forms, such as verbal abuse. It's an increasing public health concern for healthcare staff worldwide. This phenomenon affects every country, including Morocco, where healthcare professionals are increasingly facing violent situations in their daily work. Alarming statistics from Chinese
Your voice is not clear. Your voice is wavering.
of this issue, the study reveals that a significant percentage of healthcare workers experience workplace violence leading to serious physical okay. Mhm. Can you hear me now?
Yes, it's
Hello?
better. It just
It is
wavers sometimes.
not proper.
Hello? Can you
Just
hear me?
please.
Yes, I can hear you
I
right
think
now.
that
Sometimes it wavers.
there is poor
Hello?
connectivity. Mhm.
Yes, carry on. It's
Uh-huh.
okay right now.
Yeah, I'm sorry for that. Okay. Well, workplace violence is specifically defined as the intentional use or psychological aggression against individuals in place of employment. This form of violence can manifest in various ways, including physical, intimidation, harassment, and verbal abuse. The primary intent behind this action is to harm, threaten, or insult the victim. This definition encompasses a broad spectrum of behaviors from over physical attacks to more subtle forms of psychological intimidation. Our study aims to comprehensively assess the landscape of workplace violence across healthcare facilities in northern Morocco. We intend to explore the prevalence and types of violence experienced by healthcare workers, identify the most affected groups, and examine the contributing factors and potential consequences on both staff well-being and patient care. By conducting this thorough assessment, we hope to gain a deeper understanding of the current state of workplace violence in the region, which will inform the development of targeted intervention and policy designed to enhance the safety and security of healthcare professionals. Our ultimate goal is to create a safer and more supportive work environment for all healthcare workers in northern Morocco. To achieve our study objectives, we conducted a cross-sectional study between April and June 2023. The study involved 404 voluntary participants, including both nurses and physicians working in healthcare facilities in northern Morocco. For data collection, we utilized a comprehensive questionnaire developed by International Labour Organization, the International Council of Nurses, the World Health Organization, and Public Service International. This standardized tool ensures the reliability and validity of our data, allowing us to capture detailed information on the prevalence and types of workplace violence, as well as the experiences and perception of the healthcare workers involved. Ethical considerations were paramount in our study design and implementation. We ensured that informed consent was obtained from all participants by clearly explaining the purpose of the study, the voluntary nature of participation, and the measures taken to ensure the confidentiality of these responses. This transparency helps to foster trust and encourage honest and open participation from the healthcare workers involved through enhancing the integrity of our data. The questionnaire was distributed online, providing participants with convenient and accessible means to share their experiences and perceptions. Following data collection, we conducted a quantitative analysis of these responses. This approach enabled us to systematically analyze the prevalence and patterns of workplace violence, as well as identify significant correlation and trend within the data. Our analytical methods ensure robust and reliable findings could inform future intervention and policies. Our study included 44 participants from the northern region of Morocco, with a mean age of 34 years. Of these participants, 56 were female and 15% were married. The sample predominantly consisted of nurses, who made up 76% of the participants, while physicians comprised 23%. These demographic details provide a clear overview of our study population, allowing for a better understanding of the context in which workplace violence occurs. Big groups may be affected. Regarding the procedures for reporting incidents of workplace violence, our study revealed significant gaps. Specifically, 65% of participants reported an absence of formal mechanism for reporting such incidents. Additionally, 68% of the respondents indicated that there was a lack of encouragement from their institution to report this occurrence. This finding highlights critical barriers in addressing workplace violence, as the lack of formal reporting structures and support can prevent healthcare workers from seeking help and obtaining justice. This underscores the necessity for healthcare facilities to establish and promote clear, supportive reporting procedure to effectively address and mitigate workplace violence. The study sheds light on the complex concern and perception related to workplace violence among healthcare staff in Northern Morocco. The finding underscored the critical importance of addressing this multifaceted issue within healthcare setting. Workplace violence not only affects the well-being of healthcare professionals, but also has broader implications for the quality of patient care. The study's results call for urgent action to develop comprehensive strategies that include both preventive measures and effective reporting and support systems. Further research is essential to explore the underlying causes of workplace violence and to implement measures that promote a healthy, sustainable care environment. By doing so, we can ensure the safety and well-being of healthcare workers and improve overall healthcare delivery. Thank you for your attention. I cannot share all the results, especially analytic ones, because they are the subject of a publication in progress. Thank you for your understanding.